Good afternoon. Welcome to Supporting Patients with Cluster Seizures and Clinical Strategies and Shared Decision-Making for the Epilepsy Track. This is the pre-conference session PC005. Make sure that all cell phones are turned off until the session has ended. You may earn 4 nursing contact hours for attending this session. In order to earn the contact hours, you must attend the entire session and complete the individual session evaluation and the overall conference evaluation online. My name is Sarah Henry. I am just the moderator today. Our speakers today are Sandra Dewar, Deborah LaBelle-Scarfo, and Kathryn A. Sandra Dewar, RN MS, is a clinical nurse specialist for the UCLA Seizure Disorder Center and the assistant clinical professor at the School of Nursing at UCLA. Her undergraduate and postgraduate degrees were obtained in South Africa. On immigrating, epilepsy represented a new field of practice for her, for she quickly became intrigued by the clinical complexity of this diverse disorder and has dedicated her career to the care of people with epilepsy. To this end, she has served on the Professional Advisory Board for the Epilepsy Foundation of America and has been active in several subcommittees and task force of the American Epilepsy Society. Her participation is frequently sought for expert advisory panels in addition to her clinical practice. Sandra has keen academic interest and has authored and co-authored several published research studies and book chapters. She's a staunch proponent of the notion that nursing leadership needs to advance in parallel with clinical and scientific advances in epilepsy. She's currently a co-PI of a qualitative scientific advances in epilepsy. She's study of treatment decision-making in epilepsy. Treatment decision-making has been little explored in epilepsy and represents not only an important aspect of self-management, but a timely and relevant topic given the expansion of treatment options in epilepsy. Sandra, if you will let everybody know who you are. Deborah LaBelle-Scarfo, BSN CNRN, received her BSN from the State University of New York in Buffalo and has extensive experience in caring for patients with epilepsy. Her role as a nurse clinician in epilepsy and neurodiagnostic at Duke University Hospital in Durham, North Carolina, includes educating, monitoring, evaluating, and caring for adult and pediatric patients with epilepsy who are being treated medically and surgically. Ms. LaBelle-Scarfo is a treasure of the Triangle chapter of AANN and has received several awards, including the Norma L. Harris Award for Excellence in Nursing Practice and an AANN Excellence in Clinical Patient Care Award. Deborah? And Kathryn A. RN has extensive clinical experience in an epilepsy nurse clinician in the Department of Child Neurology at Virginia Commonwealth University, Richmond, Virginia. She has contributed as a sub-investigator to numerous clinical trials and currently coordinates pediatric and adult trials in epilepsy. Ms. O'Hare is a member of several professional organizations, including American Epilepsy Society and the American Association of Neuroscience Nursing, and is on the board of directors of the Association of Child Neurology Nurses. She has published extensively in peer-reviewed journals such as Neurology and Annals of Neurology and received a community partnership for the Ethical Research Award. Please join me in welcoming Sandra Dewar, Deborah LaBelle-Scarfo, and Kathryn A.
I just wanted to start by thanking everybody for coming today and to welcome you to the session. Wonderful to have you here on a Sunday afternoon. We spoke about the CEs, just a couple of housekeeping things. The post-test evaluation is in your packet. The pre-test is in your packet. If you could make sure that's filled out before we start, that would be good. And the post-test needs to be completed and handed in at the end of the afternoon. We will have 3 presentations between now and 3 o'clock, and a roughly half-hour break from 3 to 3:30, and there's snacks, I think, in the back of the room or outside the room. And then the last hour and a half, we will have a workshop where we'll remain in this room together. We've got some case presentations and a more informal, interactive time together. I wanted to take the opportunity just for a few thank yous. First of all, to thank the Annenberg Center for the Health Sciences at Eisenhower for coming up with the idea for the project, and also Corda and Upshaw Smith for sponsoring the presentations today. And a very big thank you to Michelle and Judy, who are the program managers for this and have worked very hard to keep us all on track for the last 8 weeks. And Alex, who is our medical writer and has contributed greatly to the slide presentations. And also great thanks to Kathy and Debbie for enormous effort in putting the slides together on top of everything else they have to do. We would like to save questions until the end of the 3 presentations, because I think there's a lot of material to impart, and questions after this each talk may preempt what is coming up in the next talk. So just one last point. I thank Annenberg for raising awareness on this really significant topic. I must say I was a bit surprised when we were asked to speak on clustered seizures. I think it's the first time a formal presentation has been made on this topic. And it is timely for several reasons. First of all, there's increased availability of video EEG monitoring around the country, which means that we're provoking seizures and run the risk of clusters. There's a much clearer consensus about when to refer patients. New formulations for the control of seizures in the community are being prepared. And there's a very high interest in the mechanisms responsible for seizures that occur in series. So I think it's an extremely important topic, and thank you for giving your attention to it this afternoon. And with that, I think I'll hand over to Kathy, who's our first speaker. Can you hear in the back of the room? Is this loud enough? Yeah.
I would also like to thank our sponsors in the Annenberg Center for helping put this project together. It really is very nice that people are recognizing this very important issue that our patients find themselves into. So the learning objectives for the meeting are to appropriately assess a patient for seizure clusters, critique a nursing strategy for a patient with seizure clusters, evaluate new treatment options for seizure clusters, and to develop an individualized treatment plan based on shared decision-making when a patient who has cluster seizures. Okay. And we'll review those again when we're actually doing our hands-on workshop. These are my disclosures. And just to let you know, we will be talking off-label on several issues. So I have been tasked with talking about recognizing seizure clusters. One of the things I would like you guys to be paying attention as we're doing the slides are to look at the dates on some of the research that's been done and just how old it is. It's not being written about very much, and we certainly want to get that changed. And there are some new stuff, but not a whole lot, and we'll go into that a little bit. So how do each of you define what a seizure cluster is? I'm sure if I went around this room, I would have many different definitions of what a seizure cluster is based on your experience with working with patients with epilepsy. So there is no universally agreed definition. There is a consensus statement, but it is dated. Many medical bodies have weighed in on the nomenclature, but we really don't have a real definition. Dr. Saragino and colleagues did publish something back in 2007, and there is a more recent article from Abu Kahil in 2014 talking about what is the definition. So these are what some of the people have said. Multiple seizures, 3 or more, a short period of time, somewhere within a 24-hour time period. It needs to be different from the patient's usual pattern, and we'll talk a little bit more about that, and distinct from status epilepticus. There is a fine line between a seizure cluster or acute repetitive seizures and somebody actually going into status. So it is distinct from that. There is recovery between the discrete seizures in cluster seizures, and it can be seen with most seizure types, but not really with myoclonic or absence. So when you look at the spectrum of seizure disorders, it's really important that we try to define this. And it can go from just an isolated seizure to what we call acute repetitive seizures. And some of the terms that are used for acute repetitive seizures are recurrent multiple, repetitive, cluster, serial, crescendo. All those terms are still used. I remember sitting in a room in the early 90s, and these are the arguments we had back then. It's still the arguments we have now, is what to call it. So, it's one of the things that we really do need to try to standardize that. Then patients go into status. They can have unprovoked recurrent seizures and then also prolonged seizures. So, like I said earlier, there is no universally agreed upon definition. It's difficult to assign a specific definition to seizure clustering. At the simplest level, according to Hout and colleagues, a seizure cluster is a closely grouped series of seizures. And so we will move on from there. So why should we establish a definition? So in the mid-90s, when we were looking at product development for the only approved FDA drug, the FDA actually convened a panel of epilepsy experts to talk about this, because it was the first time people really sat down as a group of epilepsy physicians, nurse practitioners, and nurses to really talk about what are we looking at here and trying to come up with a definition. In the consensus statement that the panel came up with was that it had to be severe, it had to have a predictable component. So you had to be able to say, if this, and this happen, then this is going to happen. So there had to be some predictability. It was distinct from the patient's typical seizure pattern. It had a recognizable component. There was definitely recovery between the seizures, and the predictable and temporally linked to subsequent seizures. So like I said, you had to be able to say, if this, and this happens, then this is what's going to happen. So in the mid-90s, the first product was developed, and we had some labeling for that. And then the NIH Epilepsy Advisory Committee came out with the definition that said that it had to be multiple seizures in 24 hours for an adult, and multiple seizures in 12 hours for children, because clusters in children are different than the clusters that you see in adult patients. The International League Against Epilepsy came out with a definition of what a cluster is, and they said it's an incidence of seizures within a given period, usually one or a few days, that exceeds the average incidence over a longer period of time for the patient. That doesn't give us a whole lot of real information to go by. So it was more than a single seizure, but less severe than going into status, is basically what they came out with. So what is the prevalence? We have a real hard time trying to figure out prevalence for cluster seizures, because we have all these different terminology. There has not been a lot of research looking at this. There's not a lot of peer-reviewed articles. So it really is not well known. Seizure clusters are estimated that in patients that have intractable epilepsy to be somewhere between 20 and 47%. That's a pretty big range. Certain syndromes we know are more susceptible. Those patients with generalized symptomatic epilepsy and those with refractory localization-related epilepsy syndromes definitely are more susceptible to that. So in this study that was based, it's a population-based study that was done in the UK. The crude prevalence in this study was 2.3 per 10,000 in the general population. It was highest in the 0 to 4 age group, which was 5.9 per 10,000, and it definitely did decline with age. So those patients over the age of 70 dropped down to 0.5 in 10,000. We have the estimated, it affects about 3% of the epilepsy population, which comes out to about 0.02% in the total population. So this was a study that was actually published back in 2009. Then there was a self-report study that Haught and colleagues did in 2005 on seizure clustering. It was a prospective diary study of 141 patients. In order to be enrolled in the study, they had to have at least greater than or at least one seizure per year, and they had to be able to maintain diaries. I know we all talk about with our patients about maintaining diaries. There are many patients who just don't maintain diaries. So those were the requirements to be in this study. And what Hout found was that 29% reported clustering as a typical pattern. So it was the first real study that we had that really looked at that. So, you know, it still falls into that range. The risk factors that she found was remote symptomatic epilepsy, head trauma with a loss of consciousness, and extratemporal spikes and or slow wave abnormalities on the EEG. And some of the things that they looked at in this study, they did a very full medical and epilepsy history. They did a detailed description of seizure type, the frequency, was there a temporal pattern, and then they also did the psychosocial history. They used the Beck anxiety inventory and the Beck depression inventory and quality of life. They did the Quality 89 questionnaire. They also did MRIs, EEGs. They did an epilepsy classification. Seizure localization data was obtained by actually doing a chart review. And the patients received very specific seizure diaries that they had to fill out on a daily basis. So when you look at the historical perspective about clustering, you know, clustering is not a new phenomenon. It's been going on for as long as epilepsy's been going on. When you look back in the literature, Gowers actually talked about and recognized that there was seizure clustering back in 1901. And then in the, you can also find some data about menstrual cycle and the time of day noted back in the 20th century. And then when we became in the 1960s, when continuous EEG monitoring and now video EEG monitoring, the concept that seizures as a random event and that the influence of sleep-wake cycles was really able to be really looked at when we did the continuous epilepsy monitoring. So, you know, it is something that has been noted, just we didn't do anything about it. So what are some of the risks and the consequences? I mean, we talk about that in every day when we're talking to our patients, the risk of epilepsy, what are the consequences of epilepsy, and the talk is different if you've got somebody with intractable epilepsy versus somebody who is well controlled. But, you know, we really do need to talk about this. We also need to try to answer the question, why does a seizure occur when it does? And we don't have an answer to that. The concept of clustering implies either impaired termination or increased excitation, possibly due to secondary alterations from an initial seizure that promotes a second attack, or an excess of seizure-promoting factors, and that was published in Hout's article. So it's an important question. What are some of the risk factors for having seizure clusters? And, we have a whole list of them. Number one on the list is drug-resistant epilepsy. Changes in medication. Whenever you change a medication, when you're adding something or taking something away, the risk of having a cluster is definitely higher. Sleep deprivation, head trauma, frontal lobe epilepsy clusters do occur more. The longer the patient has had a duration of epilepsy, menstruation, and on the bottom of the list, which frequently is on the top of the list, but I move it to the bottom of the list, is missed doses. And the reason I move it to the bottom of the list is, yes, patients do miss doses, but I hate when people use the term, that patients just are non-compliant. I really would like that stricken from the vocabulary, because most patients, I do think, really do want to take their medication, and they miss their doses not because they truly want to not take their medicine, but because they forget to take medicine. So I like to put it a little bit further down the list. What we do know about menstruation-related seizures, they're characterized by a cyclical occurrence of seizures in a perimenstrual, periovulatory, or luteal pattern. And it has been reported that up to 1/3 of women exhibit a twofold increase in seizures during a particular phase of their menstrual cycle. It's not just one portion of it. So it's really important, as you're getting your patients to do their seizure diaries, that for women that still are having their menses, that give us when your menses is. When does it begin? When does it end? So we can look to see if there's some kind of a pattern there. And then what are some of the consequences of having seizure clusters? What did the studies actually show? And we do have some data from Hott in 2006, Seragino in 2005, and Sillipa back in 2008. So once again, we don't have good data for today. And certainly treatment is different today than it was in 2005. So we really do need to look at this and really think about it. So patients have an increased risk of medical complications. We know that. Seizure-related injuries are pretty significant. If we don't stop the seizure, it can progress on to status epilepticus, which is why we want to do early treatment. It can result in emergency room visits. We do know that there is neuronal injury, and we will talk about that further. Sandra is going to talk about that. And there is a poorer prognosis of epilepsy for this group of people. We also know that there is a poor outcome in children with seizure clusters, and prospective studies show that. Sillipa did a prospective study based in Finland and examined whether seizure clustering is associated with drug resistance and increased mortality. This was a very long study that they looked at. I don't know of any other study that really looked at long-term like this study did. But it showed that the outcome of patients experiencing seizure clustering during drug treatment was poorer than those that did not have seizure clustering. So the patients were followed for 37 years. The patients that died actually had autopsies done. I've not seen any other study similar to this study, and that really followed patients for that length of time. I believe in Finland it was actually a requirement to be able to do that, and so they've got some really good data that would, I think, be very difficult to do here in the United States. But they had 120 subjects. They were followed, like I said, for the 37 years, and 22% of those patients had seizure clusters. 33% of those with seizure clustered reached a 5-year terminal remission versus 77% without seizure clusters. And the risk of death during using anti-epileptics was higher in patients with seizure clusters versus those without. So it was 42% versus 14%. So it was a significant amount of patients, you know. And like I said, it was a really good long-term study that really did look at what happened with these patients. And then some of the socioeconomic consequences of seizure clustering is life disruption, missed time from school, missed time from work, greater utilization of healthcare resources. And the one thing that is not on this is the caregiver. What happens when your family member has a seizure cluster? You know, if it's a child, the child misses school, but you miss time from work. And it's very difficult to really be able to come up with how much does that actually cost, you know, the country to have that kind of stuff. So it really, you know, it really does have significant socioeconomic consequences. And so then importantly, and what we're here for is, how do you define and identify a seizure cluster? I'm sure everybody in this room that works with epilepsy has patients that cluster. So what do you do? How do you assess the patient with seizure clusters? In a health study, she talked about discussing the typical seizure pattern versus the seizure cluster, and what actually happens and how is it different. I remember when we were doing the RADARS trial, which is the study that was done in order to have Diastat approved. And I remember arguing with the sponsor because I had a patient who was fairly well controlled. If they had one seizure, that whole day they would have seizures. And it was the only time that they would do it. So my argument to them was their typical pattern for seizure clustering is 1. Why do I want to wait until they have their second seizure to treat when I know they never have just one seizure? For this patient, 1 is their cluster. So, but I wouldn't have known that if I hadn't really had a long conversation about really what did happen. So you really want to look at what does the patient's seizures look like on a normal basis, and on a day that they clustered, what does it look like? You want to review your seizure diaries. Is there a specific time of day that the seizures occur? And is there a type of seizure? Many of our patients don't just have one seizure type. So that's an important piece of information to get from the patients. Listen to the patients. I can't stress this enough. Listen to the patient, listen to the caregivers. They're the ones dealing with this, especially the caregivers. They're the ones who do. Many of our patients, once they start seizing, don't have an understanding of what happens next. So to try to get a description from them is sometimes very difficult. So listen to what the patient and the caregiver does. And also review your inpatient data, especially if they've been in the epilepsy monitoring unit. And with that, I'm going to pass this on to Sandra. Thank you. And we will take questions at the end.
Thanks, Kathy. Okay, so I just have a couple of disclosures as listed. The focus of my part of the presentation is to look at really principles of treatment, and then when Debbie speaks later, she will talk about specific modalities of drug administration. So, you know, just summarizing a couple of the main points from what Kathy said. I think the challenge of clustered seizures is that it is a hallmark of intractable epilepsy. Very rarely does somebody present with only clustered seizures. It's a hallmark of intractable epilepsy, and it is possibly a poor prognostic sign. I mean, there's no specific research that's been done on this, but it would appear that this is a poor prognostic sign. And clustered seizures need to be differentiated from frequent seizures. So patients who have frequent frontal lobe seizures, many seizures a night or seizures every night, are not clustered seizures. Those are serial seizures. Clustered seizures, as Kathy pointed out, represent a change in the pattern, in the usual pattern. So we need to be quite clear about that. So moving on. I wanted to begin just by talking a little bit about this Global Burden of Disease project. And just to give you some background here, globally, epilepsy is a leading cause of years of life lost to disease. In the US, the annually estimated cost is $12.5 billion. So the cost to patients is considerably high. In addition, the cost to families, the burden to families, and the impact on quality of life is high. The Global Burden of Disease project was important because it shows that neurological disorders have a large and widespread consequence. It also focuses on the non-dollar amount, but is a way of guiding resources and recommendations for resources. And the study itself is quite complex and was done including about 14,000 people in over several countries using surveys and questionnaires. It looks at many conditions and attempted to rank the importance of conditions. Neurology has previously been thought of as a narrow discipline with limited relevance for public health. And the importance for epilepsy is that it's one of the most treatable sub-diseases within neurology. Interestingly, the most common disease in the world, I don't know if anybody would like to take a guess at what it is. Anybody have any ideas? It's dental caries, followed by migrainous headache. So just an interesting point. This project is particularly important for neurology since we have an aging population and neurological conditions are on the increase. So that treatment and care needs to be reflected in these epidemiological changes. And we need to focus on education and support of patients and families. So this ties in with the title of the conference. The challenge of seizure unpredictability, I think when we talk to patients, many of them will rank their seizures as difficult to deal with because of the unpredictable nature of them, of seizures. And probably since time immemorial, both patients and clinicians have sought ways to predict an occurrence, and we've sought for patterns in presentation in the hopes of preventing seizures. And Hart pointed out in her paper that the temporal distribution, in other words, the pattern of seizures, is often as clinically relevant as the overall seizure frequency. And we'll bear witness to that as the talks unfold. The pattern of seizure occurrence is important in the clinical setting, partially because patients report seizure frequency and patterns often poorly, and we often see patients with limited drug history. So these are two of the challenges that we face. What is ideal is to have patients present us with very accurate information on seizure types, frequency, patterns, triggers, and compliance. Sorry to use that word, Debbie. But often this is not the case, and when patients present to us, these are the threads that we have to pull together in order to make sense of their historic and current presentation of illness. The benefit of identifying triggers means that we can identify periods of vulnerability which can be modified and possibly avoided. Patients and I think clinicians often talk about random seizures. However, there's ample evidence that many seizures are not random. And most of the studies will talk about seizure days for this reason, to separate out frequency and specifically from seizure days. And certainly cycles do exist in epilepsy. And Kathy talked a bit about catamenial epilepsy, which is one example. Other examples are patients with primary generalized epilepsy that tend to have seizures at night, and very specifically around midnight. Common precipitants are skipping doses of drugs, and sleep deprivation. So seizure clustering is an identified problem. It's a very specific entity, and it is a severe condition. It's got several characteristics. I'm only going to name 4, but it's a severe disorder. It's predictable. It's historically distinct. It's recognizable, and very importantly, it's different from status epilepticus in that patients recover between seizures, and that's a really important thing to differentiate. In terms of talking about the randomness of seizures, diary keeping obviously has had its limitations. Patty Schaefer's recently, I don't know which year it was, but she published a paper on electronic diary keeping, which is a useful thing which I think needs to be further developed. Many patients don't keep diaries, and I think it's difficult for patients many of them are not aware that they've had seizures, and the seizures are unwitnessed, so there are some limitations certainly to diary keeping, but it's the best that we've got often in determining, a patient's frequency and patterns. Variations in analyzing diaries have been used. Some of the papers have used statistical approaches, and others have used simple clinical diagnosis based on 3 seizures in a 24-hour period as being defined as a seizure. And it's, when comparing a statistical approach to a clinical approach, the clinical approach is just as strong. The statistical approach is a fairly complex measure looking at the likelihood that a seizure is going to occur on a single day, and it's worked out statistically based on when the last seizure occurred. It works on a Poisson's regression distribution. It's quite a complex thing, but I think clinically it's just as reliable to use clinical data from diaries. So 2 of the common questions that we often get asked are, will drugs cure my epilepsy? And will seizures cause damage to the brain? And I think these are enduring questions. And just to look a little bit at, whether we're likely to achieve cure from drugs in epilepsy, I wanted to talk about the Kwan and Brody study. The study was really done in 2 parts, and this is one slide from the 2002 data, which looked at the likelihood of a 2nd, 3rd, and 4th drug controlling epilepsy. And on this slide, you can see, here's the point, that the highest likelihood of control will come from the first drug. So a little over 40% of patients will be controlled on their first drug. Adding a 2nd drug will increase the chances of control a little. After the 2nd drug, the 3rd and 4th drug gives very little increased effectiveness of seizure control. The study was criticized because the follow-up was only 1 year, and subsequently the work was redone and published in 2012 with a larger pool of patients and a mean duration of follow-up of 7.5 years. Essentially, the study replicated what was done in 2002. In the meantime, new AEDs had been introduced, but curiously, the results didn't change. And we still see this pattern where roughly 50% of patients are controlled on their first drug. Adding a second increases likelihood of control by only 13%, and a third drug increases control by only 3.7%. So it's quite... sorry about that. It's quite sobering that we often see patients on 4 and 5 drugs, and yet we know this data. The study really also informs the question of how long seizure freedom can last. They did a very complex division, 4 groups, patients who were seizure-free within the first 6 months, a group that became seizure-free between 6 months and a year, a third group that had random periods of seizure freedom, and then a fourth group that were not seizure-free. What was shown here was that the longer you follow patients out, the less likely they are to retain control. So patients relapsed, if they were followed to 2 years, 31% relapsed, followed for 5 years, 38% relapsed, and followed for 10 years, almost 50% relapsed. So, and it didn't matter which of those 4 groups patients started out in. So even if they started out in the group that was seizure-free within the first 6 months, they still carried a 50% chance of relapse by 10 years. So the take-home message from this really is that one drug provides the highest probability of seizure freedom, the first drug more than the second drug, and the second drug more than the third drug. In cases where patients have failed 2 anticonvulsant drugs, surgery should be considered because we know that we have a very small chance of gaining control with additional drugs. The other lesson from this was that the response to drugs cannot be predicted early, and I put the cannot in large letters because there's a point of debate. Initially, when this work was started, with the 2002 data, the suspicion was that we could probably predict patients that would respond or wouldn't respond. But this is not true after the 2012 data. And the suspicion is now that response to drugs cannot be predicted. So I think patients with epilepsy on AEDs have to be followed for many years out. We cannot simply lose sight of the fact that somebody who's controlled in the beginning will stay that way, unfortunately. It also doesn't matter which drugs are started first. The results are the same across all drugs, including the new anti-epileptic drugs. And obviously, choice of drugs needs to be tailored according to the needs of individual patients. And then just moving on to the effect of risk factors for cognitive decline. Repeated seizures of any type pose a serious risk to quality of life and long-term intellectual function. Frequent complex partial seizures are associated with memory and executive skill decline in addition to generalized tonic-clonic seizures. I think we very often focus on the impact of GTCs on cognitive loss without taking into account the fact that frequent complex partial seizures do just as much damage to neuronal networks. Neurocognitive testing includes IQ testing as well as tests of memory and executive function. And it's actually more useful to look at memory testing and executive function testing than it is to look at IQ. IQ changes very little. The changes appear in memory tests and executive function scores. The longer duration of epilepsy tends to correlate with measures of cognitive decline, And it doesn't matter where one is on a baseline IQ. A high baseline cognitive level isn't protective against decline. Patients may just be good at masking it, but it doesn't protect them. And of course, the role of anti-epileptic drugs can't be minimized. It tends to be unclear. And certainly patients that are on polypharmacy have greater cognitive impact than on one or two drugs. So in summary, what do we know about seizure clusters? First of all, the poorly controlled seizures, whether they are isolated, prolonged, or repetitive, lead to lasting cortical brain damage. And this comes from a study by Thompson and Duncan. Patients that cluster are at high risk of status epilepticus and require immediate abortive therapy. And it's a very high percentage, almost 40%, will result in status. Effectiveness of treatment is therefore dependent on early recognition and urgent treatment, whether this is in a hospital setting or in the field. And we'll segue now to the effect of clustered seizures in the monitoring unit. Unfortunately, clusters do occur in patients that are being monitored. It's an unintended consequence, and patients in some of the studies, the first time they've ever clustered is in the monitoring unit in the context of drug withdrawal and sleep deprivation. Unfortunately, what happens when people cluster is that length of stay tends to be extended, and patients run the risk of postictal psychosis. And this afternoon we're going to talk a little more about postictal psychosis in patients with postictal agitation after clustered seizures. Furthermore, seizure clusters are not independent and cannot be used for surgical planning. And this is why length of stay gets delayed, gets prolonged, because you then have to control those clusters and then wait for a single seizure that is outside of a cluster. It's another reason why drug tapers are best done in-house as opposed to prior to admission. And I think this is another controversial issue. A number of centers I know do taper patients prior to coming in, but there's a certain amount of risk associated with that. This is an old study which is quoted very often, and it was a study that was done over 5 US monitoring sites with several hundred patients involved. And clusters occurred in 50 to 61% of patients. And they looked at 4-hour clusters and they looked at 24-hour clusters. Patients with 24-hour clusters were high. Almost half of patients who clustered were recorded at 24 hours. That's 3 seizures in a 24-hour period. And about just under 20% had 4-hour clusters. Fortunately, the incidence of status epilepticus is low and is only recorded at 3% for patients in monitoring units. And this is probably because these are witnessed events and treatment can be started immediately, whereas in the community that's not the case. Safety in the monitoring unit, I'll just touch on a little bit of this. Pat was telling me she's doing a session later in the week on safety in monitoring units, so this will tie in with that. It's really important to check the seizure log, and I'm presuming everybody keeps a seizure log as a way of recording the time of seizures, the type, and the number that are occurring within a 24-hour period. And the staff have to be trained really to take careful cognizance of that. It's no use just noticing, frequency based on your particular shift. We really need to be aware of what's happened in the shift before. And at UCLA, these are just the protocol guidelines that we use. The physician has to be notified after every GTC, after the 3rd complex partial seizure in a 24-hour period for altered mental status, and for any prolonged seizure or unusual post-ictal behavior. It's a good idea, it's the essential idea to have written parameters written for the administration of benzodiazepines. Some centers use standard orders which go into the chart automatically, and I think this is a matter of personal choice. We used to do that, but we tend not to do it now, and it is part of the protocol, but we don't write it as a given because we feel it gives too much responsibility to the nurses or perhaps a covering resident to make a decision about when to treat or not. And there are times, even when seizures have clustered, where if we've waited a long time for seizures and the purpose of the admission is pre-surgical workup, we don't want patients given benzodiazepines ad hoc and then the seizure frequency stops and you might wait another 2 weeks for a seizure. So it needs to be I think carefully controlled when benzos are given. And also just to remember, again, that epilepsy is not a one-size-fits-all. Extratemporal seizures tend to occur twice as frequently as temporal lobe seizures. And there are other subpopulations which may have greater sensitivity to medicine tapers in the monitoring unit. So we need parameters for treatment, when to treat, what to treat, the kind of response we expect, and when to seek further evaluation. And this is particularly important also to be translated to caregivers and families. So the rationale for treating clustered seizures is that seizures don't, these are the seizures that don't simply stop by themselves. And the goal is to minimize brain damage, to reduce the duration of seizures, and to improve overall health and well-being. Early treatment is justified and absolutely essential. And this is an old study also which is quoted many times and was used for the development of the Diastat rectal gel. And it was a small study, unfortunately hasn't been replicated, but they essentially showed that from the time that families in the community notify EMT that their patient is running into trouble, and to getting them to the emergency room is approximately 85 minutes, which is an extraordinarily long time. And of course, if the patient continues to have seizures during that time, the possibility of controlling seizures without significant morbidity and even mortality is high. So Diastat was an important drug because it came along it gives patients an opportunity to control a situation. It gives caregivers some control, and it means that treatment can be started more urgently than simply waiting until patients get into an emergency room. And Debbie's going to talk more about that. The big question for patients and the challenge for patients really is deciding whether what they're seeing represents a seizure emergency. And it requires very careful observation of the patient during and after the seizure. The question to be asked is, are these the patient's typical seizures? And the seizure has to be compared to the baseline. The clinical symptoms need to be observed and noted. The duration needs to be noted, whether the patient's recovering between episodes, and what the postictal period looks like. And I had recently had a call from an outpatient psychiatry unit where the patient was in a day program and had a history of clustered seizures and arrived with a Diastat gel, and they didn't know when to give it. And this was exactly the information that I had to go through with them, and it was actually very difficult because this patient had arrived just with a prescription. None of this information was available to the clinic staff, and these are staff that are not used to dealing with seizures. So, and it was difficult for me. I mean, I didn't know this patient, and so it was a tiniest experience actually. So I think when we give prescriptions for treatment at home, it's more than just giving them a prescription for 1 milligram of Ativan after a second or third seizure. caregivers need a very clear idea of what they're treating and when they're treating it. And that information in turn has to be handed on to day programs and other places that patients go where treatment's going to be expected to be given. So individualizing the treatment plan is not a simple thing to do. It takes a lot of time to do this correctly. It's based off a good history, essentially off a good history, and accurate communication, as I just outlined. People also need to know how to monitor administrations of treatment in the field, when to call for emergency help. The idea behind emergency treatment at home really is to avoid 911 calls and to avoid emergency room visits, which are costly and may not actually be in the patient's best interest. Patients that go to emergency rooms end up often being overtreated, medicines get changed, and there's a knee-jerk reaction. And so, I think that when we know that patients do cluster, predictably cluster, great care needs to be taken in individualizing a treatment plan. And we can talk about this too in the breakout sessions. And my last point on this is that this really suggests a collaborative relationship between patient and treating team. And this brings us back again to the title of this symposium, really, is to look at shared decision making. Lastly, I just wanted to present this model, which I developed from the seizure surgery literature, but I think it has practical relevance to beyond epilepsy, actually, but practical relevance today. And this is an explanatory framework which is based on the literature from 2003 to 2013, looking at perceptions of surgery and why patients are motivated for surgery or motivated against considering surgery. And we came up with this model. The patient's perspective. There's another model that precedes this, but there are about 12 factors which we pulled out of the literature that fit the patient's perspective, and this includes the patient's subjective experience of disease severity, so how severely do they rate their disease, aspects of cognitive response, there are a whole lot of things. The other variables include things like gender, duration of epilepsy, perceptions of treatment. And these are the factors that contribute to whether patients contribute to how patients manage care. The guiding factors come from the physician perspective, and in the middle of the model are the deciding factors. And at the center of these two overlapping circles holds the scale of risks and benefits, and how patients and physicians together weigh risks and benefits rests on its fulcrum of fear, ignorance, and tolerance. And it's quite amazing in the literature when you look back over that 10 years of literature. Patients who are fearful or have anxiety about treatments tend to tolerate their disease, and of course ignorance plays a part here too, and ignorance both on the parts of physicians and on the parts of patients. And unfortunately, when these two things overlap, this is what guides care, guides access to care, and guides whether patients are prepared to certainly look at something like surgery. So I just wanted to leave you with that as a thought as we go into the afternoon session. These are some of the things that we'll be looking at in the workshop this afternoon. One of the things that I didn't mention here in my talk as a major sequela of clustered seizures is postictal psychosis and postictal agitation, and that's what we will focus on this afternoon with the case presentation. So I think at this point I'll hand over to Debbie, and thanks for being so attentive.
Thank you, Sandra, and thank you all for being here, and thanks to Accorda and Annenberg for putting this important subject together. Can we let them take a break?
We were just wondering if you needed
does everybody need to stretch your legs, stand up, move around a little bit before we get into the last session? Okay, we're going to start talking about therapies for cluster seizures. These are my disclosures. And we'll first begin with management goals for acute therapy and seizure clusters. So just to review what Kathy and Sandra had discussed previously, status and acute repetitive seizures or clusters, they do represent a neurological medical emergency. Prompt recognition and management leads to the best outcomes, whether it's at home or inpatient setting. Even with emphasis on prompt treatment, over the past 20 years, there are a variety of very poorly, inconsistent executed protocols, as we all know. So our management goals for acute therapy of prolonged and repetitive seizures, this has been modified from an article from Pellock. We need to ensure brain oxygenation and cardiorespiratory function. That's always our primary goal with stopping any seizure cluster or status. So first, we want to treat to terminate clinical or subclinical seizures. Then we want to prevent recurrence of any more seizures. And then identify precipitating factors. So is there a metabolic imbalance that we can correct? Is there sodium off or something like that? And to prevent the systemic complications of cluster seizures or status. Okay, so we have our usual suspects. For our benzos, we have IV diazepam, lorazepam, rectal diazepam, which I will continue to call Diastat, IV valproate, levetiracetam, phosphene, or phenytoin. Okay, so benzos continue to be the first-line treatment. So it's considered it continues to be considered the gold standard for pre-hospital treatment of prolonged seizures or clusters. Also for status epilepticus, even in the inpatient setting, that we're all using Ativan or midazolam as long as there's no allergy to it. There's lack of data to determine what is the optimal benzodiazepine route, the dose, and the preparation. So Diastat or rectal diazepam is the first licensed FDA-approved non-IV preparation. Very important for at-home use. Before that, what were we giving our patients other than additional dosages of their AEDs and PO routes, which were not always practical. So here's a chart of commonly used benzos that we all know of, and this represents time to peak oral. So if we see diazepam and clobazam, how quickly they act, and then the variability of their elimination and side effects, pretty similar on all the benzos: sedation, lethargy, nausea. You could have irritability. In clobazam, there is constipation that is recorded. So we want to calm the excitatory brain. How do benzos work? As a class, they work on the central nervous system. So they act selectively on gamma aminobutyric acid A, so GABA A receptors in the brain tissue. The benzos enhance response to the inhibitory action of GABA. It opens the chloride channels and allows chloride to enter the neuron, and then the neuron becomes negatively charged and resists excitation. So there's a little review of chemistry, which I'm sure we all love. So long-term risks of benzos. So the ineffectiveness and need for increased dosages, dependency on them, and the dependency can cause withdrawal reactions, particularly at the higher doses for those of you who have patients that are on something 3 times a day, 3 milligrams or more, as part of polytherapy, 4 or 5 drugs. So the reactions include headache, trouble sleeping, restlessness, hallucinations, confusion, nausea, and seizures when we're taking them off. So especially in the inpatient setting, we have to be very careful when they're in the EMU and we're trying to help them along to give us seizures, particularly when it's for a pre-surgical evaluation. So what options do we give lay caregivers nowadays? So we have our PO diazepam, PO lorazepam, additional doses of their anti-epileptics if they have a prodromal that this is going to be a bad day or something is happening. And Kathy and Sandra discussed serial seizures as opposed to clusters. However, I think there are some patients that will know that if they have one every 3 weeks or 2 weeks or every 3 days, if they have a second one within a few hours, then they're going to go on to a much greater number within a 24-hour period. And then, of course, thank goodness for the PR diazepam. And I think as Kathy touched on, back in the 90s, how much work and effort they had to put in just to get this FDA approved in all the trials and everything that brought it to market. And we'll go through, for those of you who have never seen Diastat, if you haven't worked with it at all, we'll touch on that during the breakout session. And we have a used kit that we can show you how it is used and how the dosage is determined. So rectally, it can be embarrassing to patients, difficult for people to administer. So if it's not already prepared, if you have to do something with a liquid, the delivery and the setup mechanism is challenging, and it's also costing you time. If you have elderly or a frail caregiver, they can be struggling to administer anything. The overweight or disabled patient, think of the challenges in any kind of administration with them. And then concerns for sexual abuse allegations for the rectal administration. And there are several cultures that there's absolutely, they're not going to discuss it, and you should know better to not discuss it with them. They won't take kindly to it. And then we have intramuscular via syringe. Diazepam can be used with a needle syringe and is used with that mechanism to treat clusters. It's resulted in significantly slower absorption than the rectal administration, and that's been looked at in a couple studies. So what are our emerging administration options? It was disappointing to look at what's emerging as for someone that's been in epilepsy so many years, as most of us have been. So we have buccal preparations now. There's several studies looking at buccal midazolam in children and adults. However, it's not available here. It is available in Europe as wafers and tabs. And hopefully someday they'll bring it here after they do some more studies and research on it. And then we come to intranasal administration. So there's a feasibility study going on, a multi-center open label study for intranasal diazepam. And then another study showing the feasibility of intranasal midazolam for home treatment as well as pre-hospital treatment by EMTs. It can be very advantageous in the home setting as well as for EMTs, because think of if they cannot get IV access. So I think that's very important. And when talking to EMTs, there's oftentimes they can't get IV access. Then you're dealing with cognitively impaired individuals. You need to have some cooperation. So the diazepam is a microemulsion, and the spray is delivered in a bi-dose spray. So it's half up each nair, and absorption is pretty quick, and it's been proven to be very effective. So we have Sperling and Henney last year that looked at this study for feasibility and tolerability of intranasal diazepam. So they had 78 patients admitted to their EMU. 30 were treated with a single dose nasal spray at 0.2 milligrams per kilo. 65% were seizure-free 12 hours post-treatment. 35% had post-dose recurrent seizure. They did prove that the treatment was well tolerated and that the single nasal spray dose had comparable bioavailability and was equivalent to rectal diazepam. Okay, then we come to the midazolam routes. So this is a study by Wormeling done back in 2006, comparing intravenous, intramuscular, and intranasal. And you can see how rapid the IV was in the second set of towers. And then we go to intramuscular and the slower absorption of the intranasal. So IV midazolam proved to be much quicker, just like IV lorazepam or diazepam. So the Rampart study was a two-part study that investigated midazolam via an auto-injector. This it was open label, and it looked at the safety and effectiveness of this medication through auto-injector. And now the diazepam auto-injector is being evaluated in several studies. So the long-term treatment with the auto-injector for trained caregivers is that in the outpatient setting, it's very safe and efficacious to use this. So what are our administration challenges for each of these administration routes? So buccally, its slow administration is very important, and it's very important that it's absorbed through the oral mucosa and that it's not swallowed, because it's not meant to be absorbed rapidly if it gets into the stomach. The time that it takes to be absorbed is a factor if you're treating someone that's having an acute cluster. and the age of the patient. They need to cooperate for you to get that tablet under their lip so that they don't swallow it. And also, you're not going to use this during a GTC because the increased salivation, you don't want aspiration to occur. And then nasal, so the nares should be clean. And with a lay caregiver, how do you prove that? I mean, we have speculums that we can look at in the hospital. And if you consider the peds population and often having junky noses, and you can't tell them to blow or they won't blow their noses, adults, it's much easier. Deviated septums don't have an issue with this, but how do you prove that the nares is clean and it can absorb the medication? And then, challenge of the IM. So it's a needle. It's going to cause pain. It's got slower absorption than rectal routes. Okay, so rectal administration of any of the medication is absorbed much, much quicker. Majority of anti-epileptic drugs, IM injection results in greater than 90% absorption. However, rate of absorption can be highly variable. And it depends on the muscle that you're using. They say the bigger muscle is going to allow for faster absorption. IM injections are considered much more painful to the patient because it is a needle. And we have appropriate formulations for diazepam, lorazepam, midazolam, phosphene, phenobarb, and valproate. And the auto-injector, as with the syringes, absorption is going to be slower and can be more incomplete. And we've got pain, hemorrhage, and bruising at the site of injection as one of the challenges and things that people may not choose to suffer from. So individualizing our treatment plans. Sandra touched a little bit about this in her talk, and we'll go over some more concrete treatment plans with some case studies in the breakout sessions. So the IV benzo remains the most efficacious way to treat when IV insertion is possible. It's not always possible. IM benzos are being used in some areas and by some EMTs, followed by loading doses of some AEDs and the usual suspects, fosphenytoin, phenytoin, valproate, and phenobarb. So keeping with the theme of shared decision making, individualizing the plan is done between the provider and the patient and family and caregivers. It should be an honest talk, and all of us know, I'm sure, that when you're interviewing someone for the first time, you may get different stories. So it's it's knowing about the right questions, and when you think you've got every right question known to you when you're interviewing a patient, you realize that you don't. Something new comes up, or do they get pale? And they say, oh no, but they certainly do. And oh well, yeah, but that just happens all the time. So the interview and the joint decision making is very important when we're planning. And we're looking at home treatments now, okay? So inpatient setting, we've got everything up our sleeves, everything that we can do to keep a patient safe, all the medications and all the routes available to us. But at home, it's a very different story. So we have our benzodiazepines by mouth. Patients can take those when they are alert, awake, cooperative, and say no that they're heading for a cluster or a bad period. We have the PR diazepam, and still the only FDA approved at-home or pre-hospital treatment. dispensed it for at-home use. And then we have nasal midazolam. So this is an off-label use that is being used by some providers where they're having a specific pre-filled dose in a syringe, and then they're given an atomizer. So there's studies looking at that, but as we said, this is an off-label use for midazolam, and it is the IV solution. It is not a special solution that they're using this for. So apparently the oral mucosal midazolam does not state that providers are using this for at-home use, but has higher availability than oral midazolam and rapid effect and brief duration when used nasally. And then we have clonazepam. So we've got dissolving tablets that can be used mostly in adults when they have that prodromal feeling or signs and symptoms are present that they're heading for a cluster or a bad day. And I have many patients that are using that, and with success. And that's it. Any questions? We're very...
There was talks about how cluster seizures are something that's different from their typical pattern of seizures, and how if a patient in a monitoring unit does have cluster seizures, those aren't used in the pre-surgical evaluation. And I was just wondering why, and if they have found that is like a different seizure focus, or why wouldn't they be included?
Good question. So you had two parts to your question. The first part was, just repeat the first part for me.
I guess how cluster seizures are different from the
right.
typical.
The only way that we can all sort of share the answer to this, I think the only way that we would, is to really know the patient well and to try to get the best history that you can get at the time, which is often not easy thing to do. It takes time to talk to the patient and to really try and understand exactly what their typical pattern is. And certainly you would recognize a cluster in the monitoring unit simply based on time, and we have the benefit of being able to see them. The one important thing I think that needs to enter this discussion is subclinical seizures. So you may not see anything on the outward behavior of the patient, but you can see changes on EEG that would make you realize that this patient was having more frequent seizures than they normally have at home. And then as far as for surgical planning we like really discrete entities. And when seizures are grouped together quickly, it's considered to be part of the same seizure, or part of the previous seizure, and it decreases your confidence that you've got the right focus. I don't know how else to express that. I think that's, yeah.
Well, I hear what you're saying. We would like them to have their normal seizure at the normal time as they do it, but when we're provoking them.
Right, and that's why half of patients who come into monitoring units, half of them have clustered seizures. You remember the graph from the Rose data, and that's 5 centers, so it's probably pretty typical. Many of them have clustered seizures for the first time ever when they are in a monitoring unit. And this is why the tapering of medicines needs to be done in a supervised setting. It's not a good idea to do it before they come in. I had a kid with Lennox-Gastaut just last week, and the family tapered his seizures prior to coming in without telling us, and he came in status. And it was actually more than a week ago because he spent like 2 weeks in the ICU. He was an absolutely established status when he came in. Severely disabled kid. And when he went home just 2 days ago, he was like night and day. From the day that he was admitted, and I think they tapered him. He was on 5 AEDs. And the mother told me when she came in, I said, why is he having all these seizures today? She said, oh, well, we were late with his medicines this morning because they had to drive 3 hours to get to us. And I said, he's on 5 medicines with long half-lives. He shouldn't be having seizures like this just because he's 3 hours late on his dosing. And then the story came out that they had tapered him ahead of time. He was actually in status. So it's a quite dangerous. Have we tapered before? We have, but I think that it has to be very cautiously done.
Yeah, I agree. Most of the doctors at my center, the 6 of them, they're extremely cautious in tapering pre-hospital, just because if we have them in there and you have an IV, you can rescue them. But prior to coming in, no. And I think liability is an issue. And I'll reiterate what Sandra said about the distinct seizures. With a pre-surgical eval, you're looking for a distinct pattern to establish focality. So that's why they're not going to take 3 seizures that occurred in a 2 or 3 hour window, because their brain hasn't they don't consider the cortex to have been calmed down possibly in between. So.
I have a question on something you said, Kathy. You talked about that they don't find absence seizures, groups of absence or group myoclonic seizures, and as cluster seizures. And I'm not sure. I agree.
Right. Pat's question was that we don't consider absence or myoclonic to be a cluster seizures. I think with the myoclonic, those people just have so many myoclonic jerks. It's their normal, their normal pattern. It's kind of the nature of having myoclonic seizures. As far as the absence, I'm not really sure why. It's actually in several people's research, though, that came up with that. And I don't know if it's because of, absence tends to, they have kids with absence have hundreds of seizures a day that may be completely missed, and they go into absence status. And I think there's probably just that very fine line between it, but I don't actually. Okay, Sandy's got some.
But when we see kids with sodium channelopathy,
right, the Dravet's
stuff, when they get sick, and all of a sudden they're myoclonic, triple in numbers. Right?
Yeah.
So I think they deserve the.
Right. I think in Dravet that we are talking about a very different entity, and I do think because they do when they're sick, they're clustering. And I would put them in their own category, not just with myoclonic seizures. Personally, I would just put them because they're their own little strange entity, as far as that goes.
I think it's. Sorry, this is just to finish Pat's question. It comes back to the question of how we define clustered seizures, and this is what makes it so difficult, and I think it's why there's no consensus. The other thing is that people with simple partial seizures are not considered to cluster, and all the studies leave them out. So, I think this is probably a grey area. The most important thing, I think, is to know whether patients with, myoclonic seizures are likely to go into, some form of status from that. And I think then you've got to think differently about how you treat it. But JME is another one where, if they have 2 or 3 seizures in a cluster in the morning, the studies are weak in that area. Was there another question?
Yes.
Oh, all the way, yeah.
And just a clarification, what, if any, of drugs, intranasal drugs, are approved by FDA, or are they all under investigation?
They are all under investigation. His question was what if any of the intranasal drugs are approved by the FDA, and right now in the United States, none of them are. So there's a multi-center study looking at nasal midazolam right now, and diazepam. So those two are being looked at, and hopefully it won't take too long.
And is you mentioned the midazolam of it, that's pre-filled and catered to the individual patient. Is that the same case with the diazepam? Are they pre-filled?
Yes. So his question was about the pre-filled dosages for both, for diazepam and midazolam, and yes, they are pre-filled syringes, and the dosages they're delivered in half dose. So half of the dose, if it's 1 ml, 0.5 mLs will go up one nair, and 0.5 will go to the other nair. And that's all off-label right now.
And I think it's all weight-based.
Correct. Yeah. One of them is 0.2 milligrams per kilogram for the midazolam.
The other thing that's important to know is when we're using these meds, these pre-filled, because the pharmacy fills them for you, they are using the IV preparation, and the pH of the IV preparation is very different than the pH of what's being investigated in the research studies, and it is a large volume with a pH that is very burning in the nares. So, that's one thing. I mean, it's what we use. Before we had Diastat, we used intravenous diazepam and a red rubber catheter to instill it. So, but the IV preparation is a much larger volume, and it is the pH is that so that it does burn.
I'm sorry, Kathy, the pH that's in testing, that's in testing?
No, not in testing. Not the ones that are in testing, because that's actually being manufactured specifically for intranasal use. Will not be burning. Correct. Well, that's the theory. The dosage of the IV is much higher than actually what the nares technically is supposed to be able to actually absorb.
No, I'm talking about the ones that they're manufactured. Like now, we use IV midazolam nasal.
Mm-hmm.
And you're saying that what they're manufacturing, the milligram per ml is higher than what we're using when we use the IV product.
Yes, you will be. What's going to, if the study comes to fruition and to an FDA approval, the amount of milligrams per cc will be higher, so that you're going to give a much lower dosage of not dosage of volume. So
it's just concentrated, right? It's just a highly concentrated thing. One other thing, when we were working on preparing the talks, patients with clustered seizures are frequently not included. It's an excluded category for all the drug studies. So, and I think this is one of the reasons that we don't know a lot about clustered seizures and how they present and how people choose to manage them. It was quite an insightful observation. So, yeah. And also, with these nasal preparations, I think one of the studies was looked at the preparation, and then a group that were given a placebo, and I think it was Valium, Ativan, and a placebo, I think, and the placebo group did just as well as the other two groups. So sometimes seizures stop by themselves, and I think that's another reason why this is a difficult area to stop. We really don't know why seizures start or stop, and whether it's an excitatory mechanism or whether it's too little inhibition. And I think this is another reason why there's a lot of attention being given to clustered seizures all of a sudden is that mechanistically it's interesting. Are there any other questions?
I have one thing that I forgot to mention during one of my slides. The cost difference between rectal diazepam and the nasal midazolam, even though it's off-label use. The rectal diazepam can range anywhere. When I was doing my research and calling around, it went from anywhere from about $180 to $185 up to $210. So when you look at the cost comparison to the intranasal midazolam, it's about $2.50 for the atomizer and about $10 to $15 for the dose. So if you're looking at families that are strapped, as many of our families are that we see, with limited funds, they have to take, that's one of the things to take into consideration.
So you're talking about what we use now, not the cost when it's manufactured.
Correct. And yes, we've discussed that once it is FDA approved, when or if it does become FDA approved, what is going to happen to the cost then? So,
I work with a physician that will tell people to, and I'm just asking if anybody else hears this, will tell people to take an extra pill if they've had a seizure, to go ahead and take an extra Keppra if they think they're beginning to do clusters, or not Lamictal, but something to that. If they're on Keppra or med like that, or Trileptal or Tegretol, go ahead and take an extra pill if they think that they're if they're feeling like they're beginning to have another seizure in a short period. Within a...
Yeah, I'll restate her comment that she works for a physician that will tell patients to take an extra dose of their particular AED if they feel like it's a bad day. And yes, I agree. My doctors do the same for patients. They'll tell them to take an additional dose. And it depends on if they're on polytherapy, which one do they think might be most effective? If you're on 3, which has given you the longest duration of seizure freedom, or which is how they'll choose what to take the extra dose of.
I think sometimes we as providers feel it is important and necessary to do something when the patient calls saying that they're having seizures, and whether taking an extra dose of an AED does anything to stop further seizures. I don't think you're going to find that in the literature to do that, but I think sometimes it makes the families feel better that we're trying to do something, and it really does depend on what the drug is and what the drug level is. If you've got somebody who's already at a pretty high dose and with a high level, and you give extra, you can make them really toxic and feel pretty crummy, which might actually, be worse. The other thing about the cost, that we talk about was, I am old enough to remember when the Diastat study was being done in radars, and I was involved in the trials to get that. And that was the same argument, was IV Valium being given in the rectum, using that we literally drew it up, had patients draw it up in a syringe. They would have to break the vial, which was a glass vial. They would have to get a syringe and a needle. They would draw it up. They would then take the needle off. And some patients put the regular syringe into the rectum. Some people we would cut red rubber catheters to use and stuff like that. It was a whole lot cheaper, but it wasn't really easy to use. And you're trying to, while you've got somebody actively seizing and you're trying to do all of this stuff and not inject yourself, as you're drawing this up, it was, I can't defend how much it cost, because we were all up in arms about, the price, because it was so much higher than what patients were used to. But that's pretty much the same thing with all of the medications. Patients got really upset when Sabril got approved, because they were able to get it through outside sources out of the country, or at one place in the country, so much cheaper than when it actually got approved, and they no longer could get it the way they were getting it. Their fees actually went much higher. I can't defend that, but it is what it's reality. So other questions, concerns, observations? I would like to actually ask the room something, which I usually do before I start talking. How many people here work with epilepsy patients 100% of the time? Okay, so a fair amount. And how many have never worked with an epilepsy patient? Okay, that's good. Good to know. One? Okay. That's good. We really do appreciate everybody coming. And we're going to still do some stuff.
Are those of you that are working 100% of the time with epilepsy patients in epilepsy monitoring units? How many in, okay, and how many NPs covering clinics? Oh, okay. All right. So I just want to ask you about the relevance of this for you. I mean, is this a topic that you're very aware of in clinical practice, or did this? Is it a surprise that we're talking about this subject? No.
Well, for me, okay. I see it in two worlds. It's a lot controlled in the epilepsy monitoring unit. I can see when they're having seizures. I can see when they're having subclinical seizures. I can, so the cluster, we're on it. My biggest challenge is the patient in the outpatient setting who, and I live in an area where there's a lot of abuse of benzos on the street, for lack of any other way to say it, as well as other things, including Neurontin. How do I control the clustered seizures with the family that calls and I feel like I need to do something? I can't see it. I don't know it. They're telling me this. I had a patient the other day who called for a renewal on her Lamictal. Well, she was taking 3 and 4 extra a day. I'm surprised she didn't have Stephen Johnson's, because she thought she was going to have a seizure, and so she wanted to stop it before it got ahead of her, and now she had run out of her script 10 days prior. I'm like, oh my. So at the same time, she's bipolar 1, and she's got a drug history, and I'm very cautious to provide Klonopin it's really, they're my more challenging patients than the epilepsy monitoring patients, because I have brains to bounce that off. We're all seeing it, we're all discussing it. It's the outpatient world where I feel my hands are tied, and so Diastat, yeah, it's like a new thing, and I can't believe it, and people don't want to do it, and I don't know. So it's hard to tell because I'm not seeing the seizure there. And I have patients who have left my practice after getting a VNS because I won't treat their seizure with Klonopin, because if I was any good provider, I would give Klonopin, because everybody treats seizures with Klonopin, who also has a history of drug use. So it's such a challenge in terms of that.
You're right. It really is a challenge. And what we've done at where I work is, if we have patients like that, or we don't have as much of an issue with the use of it on the street. What we have an issue with is parents giving, every time they have a seizure, will give either Diastat or Klonopin or whatever. And so it's being given far more often than we want it to be given. And we limit how many tablets or Diastats that they get at a given time, and so that they have to call us to let us know that they have given it. And so that's one of the ways that we've been able to control that. The problem is, with most of these benzos, the more you use it, the less effective it becomes, and you have to continue giving higher doses. That's not true with clobazam, but clobazam has not been studied to see for using for cluster seizures. It's used on a daily basis, where the other drugs can be used for cluster seizures. One of the problems is, if you give somebody extra tablets to have on hand in case they need it, and then they start taking it all the time, now you have somebody who actually is on another AED, and then it's very difficult to get them off that benzo. and it's not being used for rescue. It's being used daily, and that's a different beast that you're working with.
That's actually quite an interesting point, is the issue of clobazam and whether you can use rescue medicine benzos in addition to clobazam. It hasn't been studied. And what happens to drug levels, we don't know. We use it, but we don't really know, chronically how the two will go together. I mean, the design of the drug is different. It's a 5-ring against a 4-ring compound. Yeah. I just wanted to also say, I think, Diastat, I was never excited about Diastat, but is that a good, yeah. But actually it's a good drug because it stays in your system a long time. So, and there's, I think with all these different modalities, there are advantages and disadvantages. And we really need, it's such a complex disease. And, the patient piece of it, which is what the last question addressed, is I think we can all attest to situations. I've got a patient exactly like that too. And I think he sells his Klonopin. I don't know what he does with it, but he's always calling for more. And so, I think, we need a lot of armor to deal with this problem. And we have to continue to fight for seizure control because we know what seizures do to the brain. And this is another thing. For many years, when I started out in epilepsy, there was, this was a debate. Are seizures bad for the brain? You remember that, Pat? All those things. Are seizures bad for the brain? Well, I think we've solved that now. And, even in the most intractable of patients, we've got to work hard to gain control. Yeah.
As good as Diastat is, it is good, but it's really, it's horrible that that's the only method we have at this point.
That's approved,
for
right?
rescue.
Yeah.
Pulling somebody's pants down, sticking something up their butt, you said...
I'm not going to repeat that because this is being recorded.
You said it's unacceptable in some cultures.
Yeah.
It's unacceptable.
Well, it's very difficult to do it on an airline if you're on an aeroplane. And that was, and I can think of a few other examples of when it would be quite awkward to do it. But
for someone over 6,
yeah.
it shouldn't be done.
And for a young adolescent man, yeah.
And as terrible as it is, how you're worried about somebody abusing it. This is America. People abuse everything.
Yeah.
So I think we have our primary focus needs to be to stop these seizures. And to give people options that are more, acceptable than what we have now.
Right.
I don't know. That is so true. Diastat was approved in 1995. It is 2015. Why don't we have new modalities? And, so we've got companies now that are looking at this, which is going to be great. It's all well and good to say, okay, we're going to do the pre-measured syringes and all that kind of stuff. If we don't have the data to back up what we're doing, there's got to be some evidence that we are using good thought processes, we're using good treatments, and that we are teaching our patients the right thing. If we're just doing it because, well, I think it's going to work, that's a bad thing. I'm a researcher. I'm really very into I want the research to be done, and we need to be able to do it. But, 20 years is a long time that we have waited for this to come about. Hopefully, we don't have the same issues with the FDA that we had with Diastat. They were so negative about it. They were so concerned about the fact that it would cause people to stop breathing. And it was like, diazepam rectally does not cause that. When you look at blood levels and in which mode of administration, it's the IV formulation that is at far greater risk than rectal. Rectal does it's absorbed quickly, but it never gets to that high blood level where you see respiratory depression. I think we're going to see that with midazolam. Obviously, we're going to see that with intranasal diazepam. We already know how diazepam works and the blood levels and that kind of stuff. So it's just being absorbed a different way. It is interesting that we say we have to make sure that the nares is completely clean. I worked with Dr. Garnett, who is a PharmD that we worked with at VCU, who did a lot of the preliminary diastat and the autoinjector diazepam studies. And one of the things that he has published was looking at a full rectum and an empty rectum. And there was no difference in absorption. So I don't know if we actually have that data on the nares, or we're just making the assumption that it has to be, clean. So, but we'll see.
It's a valid point, because I was at one of the expert panel groups, and one of the questions that came up, and can you use it if somebody's got a cold? And it's a question. I don't think it's been answered.
It was very helpful to talk about that. I am actually a nurse manager of an epilepsy monitoring unit where we have just been selected as a site to do the midazolam nasal study. And just listening to the amount of time it's taking, I know part of our angst in developing it or trying to figure out the program for doing this and helping with that research is they just bumped up the timeline. It was going to be for a year worth of data, and they just put it to like a 6-month data too. So it seems like they're trying to get more available quicker.
Well, I think with that study, the reason they really didn't bump up the timeline is they had to add a bunch of centers to get the numbers that they were shooting for. 6 months into it, they realized that we're never going to achieve our goal if we don't get more sites. So that's why it's supposed to wrap up this fall at some point. So hopefully that'll happen.
We're gonna repeat that because it's being
I can't even
recorded.
hear it.
So the question to the audience was about the study for the nasal midazolam. Are you giving that? This is a double-blinded study, so you don't know what they're getting. It's randomized, double-blind.
And we just got selected as a site, and so we have not started that yet. But yes, it's double-blinded, and that's part of what we're looking into too, because we don't obviously want to harm the patient by not stopping, by just giving the intranasal if they're continuing to have it.
Yeah. And with that study, there are specific protocols. If you are dosing whatever you're taking out and you don't know, depending on if the seizure stops or a time frame after that dose, you can go ahead and you're going to give them rescue meds. I mean, their safety is still priority. So.
Anything else? I mean, these are great questions. And we have still got quite a lot of time. Yeah, it's 3. Yeah, we thought, I think there's fresh coffee there, and I think there's something to eat back there. There's one last question, no? No. So I think we'll break for half an hour, and then we'll do the second part, and I think, there'll be some new ideas after the second part. Thank you.
Okay, I think we're going to get started with the breakout session. And this is going to be a case study, and I'm doing a pediatric patient that had acute repetitive seizures during video EEG monitoring. So we know the challenges with inpatient EEG monitoring are AED reduction or withdrawal completely, potential for prolonged seizures, acute repetitive seizures and status, change in seizure semiology, and I had just had a case that the patient's very first seizure at age 8 was a general tonic-clonic seizure, and then he's never had another one, and then comes in at 34 years old. We don't withdraw, but we decrease, and what happens? He has a GTC. for the first time. Parents freak out because they hadn't seen one in 20-some years or ever. And we always, at least the people I practice with, are always saying it's a very low chance if it hasn't happened in forever, or if that was their first presentation. So he proved us wrong. And then falls with injuries for any seizures type. And if you think about, keep in mind what Sandra talked about all these risks and the percentages of all these things that happen during EMU monitoring. So my case study is a 12-year-old left-handed male. We evaluated him last year for a second opinion regarding his epilepsy, looking for focality, and really his first visit was to characterize because he came in with no seizures on disc or anything. Everything, vital signs, weight, and height were normal for his age range. Sodium was 128 on his first visit. He had never had a report per the parents of seizure cluster or status epilepticus. So they reported that seizure type 1 typically manifests as tingling in his left arm followed by sensation of feeling like he's going to fall. This was usually followed by generalized stiffening with then rhythmic jerking of all four extremities with his eyes rolled back. So he was put on levetiracetam for that seizure. So seizure type 2, once he started the levetiracetam, he developed a new seizure type. He'll still get the tingling in the left arm. He'll know that he's going to have a seizure, then he'll stiffen. He doesn't lose awareness. He cries out and he says that it hurts. And they were occurring when we saw him on the average of 6 to 8 times per month. He had no postictal weakness and would lose sensation on the left side following a hard seizure. And when we asked the parents to differentiate, so what makes it a hard seizure, it was duration. So something that lasted a little longer instead of 45 seconds, seemingly almost 60 seconds. Seizure type 3. So he'd have blurred vision. He would report everything going fuzzy, followed by seeing double, followed by loss of sense of balance with associated headache. He complained that the headache pain was 7 out of 10. The parents feel like he cannot see well during this type of event, and those were occurring every 2 to 3 days. The vision symptoms could last 5 to 30 minutes. His pupils would dilate. He had no nausea and vomiting. He was positive to photophobia, but no phonophobia. He always needed to lie down when this happened. He may have had, by report, some loss of awareness with some of these episodes, but not all of them. Okay, so our evaluation, we wanted to switch him to oxcarbazepine and zonisamide because of reported irritability on the levetiracetam. So an outpatient wean was begun to get him off the Keppra. His birth history, he was a planned C-section secondary to breech presentation. Past medical history was only the epilepsy. Family history, father and the paternal grandmother just had migraines, so no genetic component to his epilepsy. Socially, he lived with his mom and dad. He was in 6th grade and was reported doing okay for a 6th grader. And he was in mainstream classes. He didn't have an IEP or anything. He had an MRI on June of 14th that showed a non-enhancing T2 lesion in the right posterior central gyrus with a small cystic portion along with other foci of T2 laterally and superiorly. There was no evidence of choline peak. Per the neuroradiologist, although malignancy couldn't be excluded, it was what they felt was consistent with a benign etiology. So here's his imaging, and I hope you can see the red arrow right there. There's a little cyst right there, very pronounced. So we plan to admit him to characterize seizure type 3 and to try to lateralize or localize for a phase 1 surgical eval. We repeated the sodium, that the hyponatremia may be due to the oxcarbazepine, and we wanted to complete the Keppra wean while he was an inpatient. So he came into the EMU. Day 1, we typically, on the kids, we don't change the AEDs depending on what their frequency is. He was on the following doses. So Keppra was 500 milligrams every 12 hours. That was the one that we were weaning. The oxcarb was 1200 in the AM and 1500 PM, and Zonegran was coming up at 50 milligrams every 12 hours. Day 1, we had no events, no interictals. Day 2, we didn't change the AEDs again. He had 9 subclinical events recorded in a 24-hour period. So nothing was going on that the child reported or that the parents saw. And it's always surprising when you tell the families this. Yes, I do. Okay. There we go. Okay, so we're going to watch a video of one of his seizures. There we go. And this was a nighttime seizure during sleep. And of course, he did what every one of us in an EMU hates to see, turning face down into the pillow. Okay. So seizure 1 was September 20th at 6 seconds after midnight. Seizure 2 was at 4:20 a.m. on the same day. Seizure 3 was at 7:15. So we had created a cluster for this child. And this one went on and then stops abruptly. So our acute management, he ended up having 9 seizures in a 24-hour period. So after seizure 6, they gave him 1 milligram IV of Ativan. And then after seizure 9, 1.5 milligrams of Ativan. His cardiovascular and cardiorespiratory status stayed stable at those doses. So our conference of his stay, everything strongly lateralized to the right hemisphere, suggestive of the right central parietal onset. And our team, which is quite large, suggested a phase 2 surgical with placement of a grid in the right central parietal area. So when we're thinking of outpatient management, I want this to be interactive, so please join in. What do you think, after all the meds that we've talked about, is the best thing for him in the home setting?
Well, I mean, obviously the issue is that there's only, one FDA approved one.
Correct.
So the from that, in the home setting, after they have seizures at night, it's not a big deal for the parents to give drugs. The school setting, obviously, something else would be a better choice.
Correct. So this is a child that they discussed the off-label use of intranasal midazolam for the school setting. But what is the challenge to that? Now we're dealing with school liability because they're not going to do it because it is not FDA approved. So in a child because he's a big 12-year-old, he's preteen, so that intranasal would be a great choice in the public setting as opposed to at home in privacy of his home with, maybe just mom at his bedside or dad at his bedside giving him the rectal. So that's what we're seeing as a big challenge with only having the rectal diastat for the at-home setting. Okay, lost my mouse again. Okay, so today, the parents were totally put off by the thought of implanting about 136 electrodes on the surface of his brain. So we initiated the ketogenic diet in February of this year. His seizure frequency increased to a few times a day with greater duration. So they were lasting longer after the diet started. He had low energy. He was sleepier in the AM prior to than he was before the diet. So what they did is after 2 weeks, they adjusted the diet and gave him a higher caloric intake. So he wasn't getting enough calories to start with. And I don't know if the dietitian just didn't take a look at, a 12-year-old and growth and his daily activity. Zonogram was increased to 600 milligrams every 12 hours, and then he was prescribed the clonazepam disintegrated tablets to be given after seizure number 2 on any given day. So as a preventative and precautionary thing to avoid the clusters, he was given that. I talked to the mom last week, and she had only used it probably twice in a two-week period. So I think with the higher calorie intake, he was doing a little bit better. Does anyone have anything they'd like to add as far as what you might have tried or have done differently with this case? No? Okay. I'm going to pass this on to Sandra now for her case. Oh, go ahead. Yes, he did not go into a cluster at all, so it stopped after the second. If you guys want to stand up for maybe just a couple minutes and stretch again while we switch out the videos here, feel free.
Okay, I think we're up and running. Debbie has some tricks to show you afterwards, and she'll just come around from table to table and share some ideas of administration. So this case study is a patient with post-ictal agitation and psychosis following clustered seizures. By way of introduction, this is based on Andy Kanner's work from 1996. Clusters increase the risk for post-ictal psychiatric events. And very important to remember that these can be either psychotic or non-psychotic. Most people tend to think of serious post-ictal problems as being psychotic in nature. And if patients present with psychosis, the difference in behavior between a psychotic event and a non-psychotic event is that psychosis is accompanied by thought disorder, affective disorder, agitation, delirium, and auditory and visual hallucinations, or some combination of those things. Whereas if it's non-psychotic, they don't have those elements of thought disorder, but they will wander, become agitated, aggressive, as I've got it listed here, confused and disordered in their thinking. And this is the video that I'm going to show you, because it's very difficult to show psychotic behavior. I didn't have something that gave you that. The incidence is about 6% in the EMU, and is considered directly related to the fact that we're reducing AEDs and we provoking clustered seizures. So it's something I think that we need, even though the incidence is not that high, it's something that we need to keep at the back of our minds all the time. And it's also very important when people are discharged that we don't discharge them without knowing that their EEG is completely stable and that they are back to their baseline cognition, because a lot of these patients develop post-ictal psychosis 48 hours after a cluster of seizures. So it's important to have that and bear that in mind. And behavioral changes can last from minutes to days, and generally it's more likely after a GTC, but a flurry of complex partial seizures can provoke it as well. And patients are more at risk if they have a history of behavioral complications after seizures. So this is the case study. It's a 32-year-old man with seizure onset at age 12 and refractory seizures at age 17. He has comorbid ADHD and depression. He also had periods of refusing to take his medicine and actually stopping it in between. His first cluster of seizures occurred 3 years earlier. After seeing this patient, so he was 29, so he'd gone roughly 12 years with infrequent seizures, and then all of a sudden he started having clusters and an increased frequency of his baseline seizures. He was having 3 complex partial seizures and roughly 1 GTC a month. But in between this, he was having the clusters. His clusters were reported actually every 6 months, fairly reliably every 6 months. And he'd had severe consequences. He'd had serious injuries. The police had intervened because he had become belligerent at home. He'd had many ER visits. He'd been evaluated by mental health, and he was currently in a lawsuit, and he'd gone to jail. I think he's had several lawsuits. One of them was because he held on to somebody. He was accused of assault and false imprisonment. And the story was that he'd actually held on to somebody. I don't know how they concluded what they did, but this is how serious the repercussions are. And when he came to us, he was pending a lawsuit, and I had to write a letter to the DA to explain the severity of his seizures and to ask them to take this into account in evaluating his sentencing. And he had broken up his apartment. He went into a blind rage and smashed up the apartment which he was renting, and the landlord sued him. So the description of his seizures, the clustered seizures consist of 2 to 3 seizures in a day, which are characterized by a dyscognitive state. And then he has pathological laughing and crying, which can last 1 to 2 days after the seizures. We didn't actually see that part in monitoring. We saw other things. He has no aura except for a sort of prodromal headache. The complex partial component comprised aimless wandering, walking into walls, bimanual gestural automatisms, and right face repetitive movements. He has eye deviation, and he has partial memory for the event. And this then progresses to severe post-ictal agitation with no recall and a depressed mood for many days after a cluster. The post-ictal behavior was sort of bordered on between psychosis and agitation, and obviously during this time he reports very high strength. He's completely uncontrollable, The last recorded episode was in January, just a couple of months back, where he had 9 seizures over 2 days, and he was outraged, this is his words, outraged for a week, refusing meals and fluids, becoming hyper-religious, and claiming that he didn't want to live, and he wanted to go to jail, or he wanted to go to the hospital. So quite serious. When we brought him in for monitoring, we captured 8 seizures. 3 of them were right temporal, and 2 were left temporal, of which one of those was a cluster, which we counted as 1 seizure. And that cluster, it was basically the 4th seizure, so he had 3 right seizures, and then he had this cluster of left-sided seizures. I forget what day it's there somewhere. But on that day, the seizures, his seizures get progressively longer, which is another hallmark of clustering that's recently been studied. I saw a poster at AES looking at duration of seizures. And they suggested that the last seizure in a cluster is usually the longest one. But I don't know how long you wait to get to that last one, you know, because his seizures actually bore that out. They became closer and closer together. The first and second were 3 hours, and progressively the duration, time between, became lessened. And each seizure became progressively longer. His MRI showed bilateral hippocampal atrophy. His PET scan concurred. He was on 2 AEDs on admission, Lamictal and Keppra, and he had a prescription for Ativan. And the consensus at our surgical planning meeting was that he probably needed depth electrodes or RNS, because he has bilateral imaging and he has bilateral seizures. And it's not clear how easy it would be to find one side of his brain more responsible. You know, if you can meet the 30%, you might have a chance of removing one side. But at this point, we didn't have neurocognitive studies on him. And that's, I think, played quite an important role in his workup since this. So this is his imaging. I would have liked to show you the MRI of his brain. I don't know why it's not the right image, but he has bilaterally small hippocampi, and you can see it very clearly. I've got a normal image to show you, you know, what a nice plump hippocampus looks like, and what this small, what we decided he had bilaterally burnt out hippocampi on imaging. And so I want to just hop to the ictal event now. So this is the beginning of a seizure, and the seizure is quite long. This is the 4th seizure in the cluster. And I'm not showing you the whole thing, I cut it, but just to show you, he starts out with this rather bland arousal. And then he has some bad manual automatisms. He looks around, he's clearly confused. He has a little bit of lip snacking and perioral automatism, looks to the right. His breathing is increased in rate. And he has purposeless movement. I can see it online. And then he sort of fidgets. Fairly typical of a complex partial seizure. He has turning to the left, and then he'll have versive eye movements to the right. And then he secondarily generalizes, and I didn't give you the whole of the... It's almost as if he's aware. He's looking up at the EEG behind him. And you have the feeling that he may know. And he has this right face twitch, which we described earlier. Unfortunately, the monitor tech didn't recognize this part, or the nurses were slow to get there, but didn't take long before they were all in there. And he turns, and I stopped it before the whole of the GTC part. There he goes. And okay, and then he starts. Okay, so he goes secondarily generalized at this point. Okay, so that's the ictal event. Just get this on to the second one. Okay, so the reason I showed you the whole thing was just to give you a sense of the duration. It was actually much longer than this. I cut it. And given and bearing in mind this was the fourth one. So this is the post-ictal behavior. So by this point, he'd generalized and he was starting this. This is the second time he had done it in about 3 hours. So we had risk restraints in place to secure him because we'd already seen this once.
Did you give it Milato? No. Milato? No. Brandon? Lily? Do we have the thing? Here, we can restrict his leg, no, for the leg. Yeah, we have. Brandon, calm down. Calm down.
And we'll talk about the management in a moment, but just play to the couple more minutes. Nobody could get near him. I mean, yeah.
Stay away from his feet.
Okay, so this goes on, and then they called help. So I think we can stop it.
Traitor! Shut it down! Help me! Yeah, I'm helping you. Shut it down! Shut it! Shut it down! Shut it down!
Okay, all right. Okay, we'll talk about it in a minute, but let's just go. Oh, you do? Oh, okay. Oh, terrific. We could just show. That's just interesting, that's all. So as far as prevention is concerned, it's really important to assess risk for this kind of behavior before he comes in. And I'm sure those of you that are screening patients before admission, are aware. And when, if you go to the EMU safety meeting later in the week, pre-screening of patients coming into the monitoring unit is an absolutely crucial thing. If you don't have someone doing that, you really need to really consider getting someone to do it. It's because knowing what you can expect from patients allows you to prepare for them, right? So we knew ahead of time that he had a this kind of serious post-ictal behavior. He was wearing a posy vest and obviously all the other standard seizure precautions. He had an episode like this sitting in a chair earlier in the day. He was posied in the chair. We only use big, high-backed, padded chairs for the patients who will never sit in a lightweight chair like this. But he ended up on the floor, even though he was in a posy restraint. And we had to get security to come and help us get him back into the bed. And he was just wild. He was all over the place. And you can imagine, the risk to his safety with this sort of thing. And if this happens in a mall and they call security to a mall, he's going to be forcibly restrained and end up with, all sorts of physical injuries. And if he does this in jail, he's going to be hit by the police. I mean, it's a really very bad situation. But from our standpoint, it's important that we know about it beforehand and that the staff are warned. It also influences the taper. So we were very cautious about the taper of his medicines, but even so, we had this cluster. A cluster it's post-ictal psychosis and agitation. One of the risk factors also is when this behavior starts after 10 years of epilepsy. It's a hallmark. We need to review the EEG for ongoing subclinical episodes, and obviously in an EMU you've got the advantage that you can look back and make sure that they're not having things that you're not aware of. Tracking seizure frequency, as I said, according to the log is important, and GTCs need to be prevented, so you might not want to taper somebody completely with this kind of history. Andy Canner has written quite a lot about this subject, and one of the things that he suggests is low-dose prophylactic treatment. We didn't do that in this case, so you can give a little bit of Haldol for 2 days prior to admission. But I think that there's a place for that when you consider intracranial evaluations in somebody who has a history like this, because he clearly needs to be evaluated for surgery. I mean, we're not finished with his workup, but we have to be, if we put electrodes, place electrodes, we've got to be able to manage him carefully, and you can't get near him. So I'm dreading the day that he does come back. And I'm certainly going to suggest that we give him some Haldol for 2 days prior. And you can continue the Haldol during the evaluation as well. The other question is whether patients have low sodium correlating with post-ictal agitation. And there was a study that looked at this in the early days before we had all the drugs we have now, and it was done specifically in patients, looking at patients with who are on carbamazepine. But the control group who were not on carbamazepine also had low sodium. So I think it's a point of debate. But I've left it in because I think that it's quite important to think of metabolic issues that might contribute to delirium and behaviors. I mean, we saw this situation that if you had somebody being admitted to you through an emergency room and coming in a delirious state, you may not know what had happened prior. And your first thought may be seizures, but I think the second thought in the back of your mind needs to be whether there's something metabolic going on, or something as simple as aspiration pneumonia that can cause a delirium. I mean, this is post-ictal agitation, but delirium is slightly different, but nevertheless it's a post-ictal behavior. So acute management, and we can talk in the group too, I'm sure that you're familiar with this, is really to stay calm and stay with the patient. I mean, it's very difficult to remain calm when you've got patient doing this. And this also a good idea to limit the number of people that come into the room, because the patient's in a confused state and very difficult. You cannot communicate with them really. They're not going to follow command, but they may respond to a calm one person talking calmly than a lot of faces. I also think that we make patients more agitated if we slap an oxygen mask on their faces at a time like this. And, unless there's clear evidence that they need it, which is not very often, we probably don't need to rush in and give oxygen. Limit the number of people in the room. And if the patient's out of bed, close the door to keep them in a confined space. Remove any dangerous objects. Restrain them if appropriate, if you can get to them. Sedation as appropriate, we can talk about that. And then we need to also think about considerations for discharge home. And I already said, one of the things, we don't want to send someone home and then have them do this 24 hours out of leaving. In the long term, prognosis is of great concern, since some of these events may become incorporated into interictal psychopathology. And that is very concerning, because families are then left to deal with this. So it's a situation which we need to diagnose and have a treatment plan. And it speaks very seriously to the importance of controlling clustered seizures in the community. Patients who are like this should certainly be considered for surgery, because surgery and drugs together may be the only way to reset the neuronal circuitry. And post-ictal psychiatric events are not a deterrent to surgery. except that we have to deal with them, right? And I just wanted to show you one last slide here of EEG. It's just a very small, I don't know how to get this to go forward. Oh, sorry. This was his EEG, just a fragment of it because it went on for a very long time. During that kicking and hyperactive, in fact, I think this was a little bit after because there's no artifact on here which you would see if he was moving around, but he'd calmed down. You still couldn't see him, but notice how slow the EEG is. You know, when somebody has this level of slow EEG, you're not going to be able to reason with them. So if you have EEG in the room, it might be helpful, you know, if you can recognize something of the patterns. I mean, we don't really expect nurses to read EEGs, but certainly a really slow pattern like this will give you some clue that, you know, you've just got to sit this out until time passes and he's more cooperative. And then Alex had that EEG, the MRI, right? It's on here. I don't know where to put it in this thing. And whilst Alex is putting this on, I looked at some of the other literature, and there was quite an interesting report published last year of a patient who had post-ictal psychosis and then murdered his mother. And the case was written up. So although, you know, it would be rare for somebody in a situation like this to attack someone else, there are cases where this has happened, and there was this very recent one, and he became completely psychotic and believed he was being told to. First of all, earlier in the day, he threatened his sister, and she left the house, and then he was told by God or somebody told him that he had to murder his mother, and he literally stabbed her to death in one of these psychotic breaks. And then at Orrin Davinsky, who's one of the senior epileptologists in the country, and a couple of other people, I think somebody from Florida was on the paper, and obviously they were involved in the legal case. Okay.
You know, we have, once you know, from our perspective, all of us, once we live this on the other side and we see behaviors that, you know, to the general public is bad behavior or whatever.
Right.
Could be seizure. I couldn't help but think, and I know this, you know, we know more information about this now, but the pilot of the German wing, you know, plane that crashed into the mountains in France and killed all those people, knew he had a medical condition. You know, this was like as it first came out, and everybody's thinking is psychiatric, but still, I thought, you know, this guy could have been having a seizure. I mean, that's because it's the world I live in all the time. And, you know, his breathing was normal. Well, that man's breathing may have been, your patient's breathing may have been normal during the event. You know, he intentionally, now we're finding out that wasn't the case, but I couldn't help but think, you know, who's to say? He didn't respond, you know, and intentionally put it into a nosedive. Your patient could have intentionally put, you know, just all that stuff that we don't know, that we assume is choice behavior, which really, I mean, I've seen it so often now that I have the luxury of being in an EMU and seeing post-ictal behavior and saying, wow, you know, we arrest people for that, people get labels because of that, they lose their housing, their job because of that, and it's really metabolic. I mean, you know, medical thing.
I think that the difference though is that this is not choice behavior. I mean, if they have very little control over their behavior.
Right, but
you know,
who's to say? I mean, you know, I don't. That's the first thing that comes to mind. Maybe he had no choice. I don't know. I'm using that as an extreme example. I have a. Except that when he got in, I mean, that's another whole subject. But you know, when he started out that day, by all accounts, he was completely normal, of sound mind and. To the outward person, clearly not, but yeah. But here's the MRI. Sorry, just get back on this. So you can see the normal hippocampus is nice and plump on both sides of this brain, and you can see the
the blue bar is twice or two, at least a third more than the red bar, and he's abnormal on both sides. And bilateral disease is actually one of the risk factors for post-ictal psychosis. So, it's something that we need to bear in mind as nurses, is really to pull the whole picture together when you're seeing these patients and not just focus on what you're seeing on the EEG. You need to know the whole picture. He has subsequently had neurocognitive testing done, and his IQ is actually quite good, which, and I said to you earlier on that, IQ testing is really not a good indication of the impact of epilepsy, and is not a good measure of long-term either. There are other aspects of testing which are more important, like memory, and very specifically executive function tests, because it tests the circuitry between the temporal lobes and the frontal lobes. And he clearly shows bilateral reduced memory, worse verbal than non-verbal memory. And we haven't done a WADA test on him yet, but we're presuming he's right-handed, that his left hemisphere, that he's left dominant for language. But we also think that's where the seizures are coming from. So it may be diagnostic, it may be helpful, but we haven't got as far as doing his depth electrode study yet. But certainly, from a nurse in a monitoring unit, it's really important to know all these different nuances as the information is available. Yeah.
What was the discussion with him about being in a posy and being restrained while he was not in an ictal state? It's a good question. He was very willing, actually. And we sort of had to win him over. In fact, this was his second admission. He came in some months before, and he only had one seizure, so it wasn't sufficient for a surgical workup, and he had to come back. So we had a chance to get to know him a little bit. He presented as quite a withdrawn man, and I think he's pretty disabled by his epilepsy and the post-ictal behavior. And he doesn't have a job anymore. He had been working, but he's now on SSI. At home, he has a caregiver, a man, who basically looks after him sort of 24 hours a day. We're never quite sure what the relationship was between them, but he was a devoted caregiver. And so the burden on society and the burden on he's dissociated from his family. They don't even remember his birthday. So the burden for these patients is enormous. But he was willing to be restrained, and then he was earlier on in the day. We'd had this very violent episode he was on the floor, and he then agreed to have wrist restraints, and then this occurred 2 hours later. So, sorry, Pat, there's just one behind you. Yeah.
Right. So, I find this very interesting. I work in an institution which I've seen a lot of ICU, post-ictal psychosis. The restraint part bothers me because in the institute I work in, we have a no restraint policy. Especially in light of the psychosis.
Yeah.
If there's a known factor, and we get a lot of guys who come in who beat the crap out of everybody, they usually, we don't restrain them. We get them with a sitter,
right.
And then we anticipate the seizures, and we don't let them progress. Any change at all, we're walking around with Ativan in our pocket. Now, if there's a situation in which, I've been involved, I can't count how many times I've been swung at and blah, blah, blah. That's not the point. The point is that we intervene before the restraints come, because it's our experience. I work for the federal government. It's my experience that the restraints just escalate. It's like having people in the room, and there's more harm than good. So I was wondering, the question is, that your hospital obviously has a restraint policy. Was this gentleman on the ICU? So why wasn't he in leather restraints as opposed to soft restraints? And why was his movement allowed to be so destructive?
I think for exactly the reason that you say. We use posy vests a lot for patients that are likely to have generalized tonic-clonic seizures, just from a safe, they're not tied down. It's just to keep them, in one place so that there's not too much moving around. But I think that it's safer to have somebody in soft restraints where they've got some movement, than it is. I certainly don't think he needed leather restraints. He didn't need restraining. That's because we knew that this would probably pass, although, you know, he's been known to have these programs for days on end, so we didn't quite know how long. But he had been treated, so this didn't go on for days.
No, go on, I'm sorry.
Yeah, so, but it is. I don't think there's any clear answer, and we can see what other people's experience has been, but I think you've got to do your best with what you think at the time, and we couldn't have him swinging around. He would have been out of the bed, he would have been on the floor, he would have been injured, and so would the nursing staff. So, you know, we allowed him to do quite a lot of kicking. In fact, when the security arrived after this event, they used a draw sheet and just sort of trapped his feet, and I didn't show that to you, but just so that they didn't have, nobody had to handle him. But I mean, it was hard to even get medicine into him because you couldn't get to his IV.
Absolutely, absolutely. No, I was just curious if there was a hard and set rule in terms of why wasn't there, with the known history, why wasn't Annenberg given 40 for the rest of this? It was. Yeah, this is the fourth seizure of the morning, so he'd had. And so they didn't. And he was back on his reloaded. I think he'd had IV reload. Well, we wouldn't have used that. We just used the medicine that he was on, and he came in on, what did I say, Keppra and Vimpat. That's very interesting. I find it fascinating that there's different hospital policies, you know, for restraints.
It's not so much a hospital policy as a program policy, and I mean, we haven't written this down anywhere. It's really a case of using, you know, your clinical judgment. Yeah. Sorry.
Piggybacking on that, we have had several of those incidents in our epilepsy monitoring unit as well. And one of our first ones that we realized is that security came in and treated them as if it was a person that knew what they were doing and choosing. And so we did education sessions with security on what post-ictal psychosis was, and, you know, what we might see in epilepsy monitoring unit, and then we notify them ahead of time when we know that this is a potential, that this is that type of patient. Just they do treat them differently if there's a person coming in and purposefully being aggressive and agitated versus someone that we can explain to them, this is a post-ictal psychosis, this is a medical issue. It's not because they're truly trying to hurt us in the right mind.
Good
so
point.
That was a good benefit for the unit.
It's a good point. Sorry, Pat's been.
I'm not familiar with that study with the house dog.
Yeah. Yeah, and allows you to, apparently, and you can successfully monitor without having, you know, this sort of way. Certainly that's what they've quoted. I haven't, but I'm going to try with him for sure. Yeah. I mean, we've had other really bad situations, but I didn't think of using prophylactic Haldol till we were preparing for this. Yeah.
Quick point. We use Risperidol.
Right.
PO Risperidol and IV if necessary. And we have psychiatry involved.
Right.
Treatment basis. Because we get really bad patients where I work. So, but you know, you mentioned Haldol. Risperidol works really well.
It does. Yeah, I've used. Yeah, we do use that too. I mean, I'm just quoting the can of paper. Yeah. Yeah.
Facility, you say you use sitters and no restraints, but what about if they're falling and getting hurt? Then what are you doing?
As you mentioned, we keep the door closed and we keep the rooms padded. Forward padded mattresses. Okay.
With mattresses?
Yeah.
Okay.
Yeah. All right. I work at the National Institute of Health, so we get a lot of really bad cases.
But yours is more a psychiatric unit, or no?
No.
Oh, okay.
We have an EMU, which is just a small part of it. We do a lot of really invasive neurosurgery and a lot of neurological.
Okay.
We have full monitoring.
Right. Yeah.
I could ask for maybe a clinical clarification. Post-ictal psychosis you're talking about versus PNES. Is there a way for you to know that this has to do with the seizure itself, versus there's a seizure, this is the PNS.
Yeah, I mean, I think there's a very big difference. But I think maybe what you're asking is, how do you differentiate? Can you tell whether somebody is confabulating behavior? Is that what you're really getting at? Or
Well, I'm going to neurological because moving, your EEG is going to be artifacts in it. But, from what my knowledge is of PNES, is really hard to treat. You can't treat it in AED. So, how do you treat then this patient? Are you certain this is a particular event, or could this have?
Yeah, I mean, the psychogenic non-epileptic seizures, I agree, can be difficult to diagnose, but, there are lots of features that are completely different to what he did. So, you would certainly not, a PNES patient would have no EEG correlate. And you would look at a lot of factors, that would increase your the likelihood of it being PNES versus a seizure, and that would be the duration of the event, the fact that it's asymptomatic. I mean, his asynchronous. His behavior is asynchronous, I agree, but, he was already post-ictal. We'd already seen the seizure onset. We knew he had a seizure. The presentation is definitely a seizure. It's not, he's dyscognitive. You can't really confuse that with an episode of psychogenic seizure. So I think but you're right, it's very possible that if somebody came into an emergency room with this, you might not really know what you were looking at. I mean, we happen to see a lot. I still would never say that I'm 100% sure that something's PNES. I might say 99, but never 100. But I think for, hospitals that are, not treating epilepsy on a regular basis, you could probably run into trouble with that. Yeah, okay. Yeah, it's a good point. Yeah, she was just saying that she hasn't seen PNES patients become aggressive, and that is true. I've never seen a psychogenic patient become aggressive, except when they don't want the diagnosis. Okay. And there was another question in the back.
I was also going to comment that his history. I mean, he's lost his job. He's trashed his house. That's not very PNES.
No, and he has a long history, so yeah. So there's a lot of noise up here, so it's hard to hear.
I'm just curious, with prophylactic, how well for preventing sickle psychosis, has there been any studies about it?
Any studies about?
About it being effective in stopping clusters?
Well, I wouldn't use it in a cluster. I mean, I think the suggestion was to use it for patients that have post-ictal psychosis after a cluster. So, this man we know has. So, and you wouldn't use it for many days. I mean, the suggestion is that you use it for 2 days before, and then for the duration of monitoring, especially with someone who's going to have depth electrodes placed. And, your goal there is to keep them safe. So I think it's reasonable. Yeah. So the question is, at baseline, does he what? Not really, no. But the concern always is that the interictal behaviour will deteriorate, and I'm not sure what the mechanism is and why. But this is a concern. But in between, he threads beads and he makes jewelry, and he's quite depressed. I never saw him smile once in 2 admissions. The Keppra worsening. Sorry, I'm sorry, I can't hear you too well. Yeah, I left it in because I was hoping somebody would challenge the fact that he's on Keppra. And, there's no clear evidence about Keppra and agitated behavior. It's all anecdotal. And certainly it wouldn't have been my choice or a choice of drug for somebody like this, but he'd failed so many others, and he came in on Keppra. When he was discharged, we left him on Keppra because we can give it IV and we can get good levels because his seizures are bad. But we did caution the family, or this caregiver, about the Keppra. And I've stayed very closely in contact with him because we are concerned about the Keppra. The other thing is that he went out with a prescription for Ativan, and we told them, that if he'd had 2 seizures in a day, that they should then use the Ativan. They've never ever used the Ativan. They just didn't understand it. And so, he comes in with this listed as a rescue medicine. I said, well, did you use it and how was that? He said, no, they've never ever used it. So, it takes a lot of work to have people cooperate with the plan and to really understand it. I don't think they understood it. Yeah.
But the Keppra, Keppra doesn't have, there's never been anything that suggests that Keppra contributes to cocaine.
No, but it contributes to agitated interictal behaviors, and there's been some concern about suicidal ideation, and but it's not an isolated concern. It occurs with many drugs, including Dilantin, So, and of course, that's the problem with Fycompa, is that people are worried about that black label. And when you think about it, it's anecdotal. It's based on the experience of 1 or 2 people. And nobody really wants to go looking for trouble. So then it gets, reputation that if somebody is having trouble with agitation, that you don't give those drugs. But I think we need to know a lot more about mood-related side effects from AEDs. I just wondered if there were any other questions on Debbie's case presentation. And I also wonder if there aren't any more questions, but what the incidence of post-ictal psychosis is and agitated behavior in kids. Those of you who are in peds, do you see this or no?
I've had a couple adolescents that have had what I consider mild agitation, but never psychotic behavior that I've seen in 12 years.
The youngest that I've seen is kind of at adolescent age, and the 2 kids that I've seen today have kind of low seizures too, which they have kind of other psychiatric issues as well. So it's hard to keep that right.
Do you want to add anything?
What I thought maybe we should do is, does anybody have an interesting patient that you'd like to talk about? Get some feedback or anything like that.
Well, yeah. I wear 2 hats. I work in psychiatry and I work in neurology, and I think, or I'm pretty sure, nationwide there's a big drift there, and there shouldn't be. So we're catching patients with psychotic and mood disorders on the neurology side, saying, well, of course, they have a seizure, we see it, this is post-ictal behavior. But to go in through the other door and work in inpatient site, and I can't help but wonder when some of these people come in with their first psychotic break or first, we assume sometimes when we wear a psychiatric hat that it's schizophrenia, it's their first break, and to begin to educate psychiatry to say, maybe you need to do an EEG. Just maybe you need to do an EEG. And I've seen it 2 very recent cases. We had a patient in the epilepsy monitoring unit. She was 32 years old. She had had a generalized tonic-clonic seizure, I'm going to say back when she was about 12 or 13. Anyway, that got sort of put behind, and she eventually comes to us in the epilepsy monitoring unit with a diagnosis of schizophrenia. She's on all sorts of psych meds, had multiple psych admissions, very combative. On her admissions, was brought to the ED, would then go on into psych. And being that she was 32 years old, they started to think maybe we should do an EEG because she had a seizure way back when. She refused because she was agitated, annoyed, angry, and refused her EEGs in her psychiatry world. She comes to us. We put her in the epilepsy monitoring unit. She's on a medication now. No antipsychotics have worked, so now we're resorting to old med of Trilofan to manage her schizophrenia, and it isn't working. And she had right temporal lobe epilepsy. We stopped all the psych meds. She was in for a VNS evaluation, potentially VNS. We stopped all of her psych meds, put her on anti-epileptics, and she rarely has a seizure. Her post-ictal behavior, she'd wake up, watching her in EMU, she'd have her seizure. At the end of her seizure, she'd cough, she'd have to run to the bathroom, evacuate her bowels, and she'd come back agitated. She was pulling on her leads, and if you approached her, she became very, she needed her space, very aggressive. But you could sit and play dominoes with her. She'd talk to you as long as you didn't get in her space and let the post-ictal phase run its course. And you would never, without seeing it on EEG, never guess. She's been arrested multiple times. She'd wake up at night. She was banging on the neighbor's door because they were having a party and didn't invite her. She was found hosing her neighbor's clothes on the clothesline that were out drying. Just really odd behaviors, and she got labeled schizophrenic. I follow her in clinic. I've been following her for 2 years now. She's done remarkably well. It's what door they come in. I guess that's what.
Well, I think you raise a really good point in general in epilepsy, and that is that there's not enough involvement of psychiatry. It's a huge gap in epilepsy care. I don't think that there are 2 psychiatrists countrywide that work, dedicated their lives to epilepsy, but those are the only 2 that I know, and. For the most part, it's very hard to get psychiatrists to come and help out. You have to approach the general team, usually, to consult, and they don't really want to see patients in an acute setting because they're going to see them once and they're not really going to contribute long-term to the care. It's very concerning. I don't know, when you consider that the psychiatric comorbidities are such an enormous part of epilepsy, it should be a no-brainer that we have psychiatrists on the team. And I don't think that exists anywhere in the country. I'm working with a comorbidities group at the moment, and we're going to send out a survey to see, what neurologists are comfortable treating and what they're not comfortable treating, as far as SSRIs go, recognizing depression and screening patients for depression and anxiety. And those are serious problems. It's not post-ictal agitation, but it's part and parcel of the disease, and yet it's a really neglected area of treatment. Yeah, I'm sure we can all cite exactly examples. And the unfortunate thing is that I think these patients do end up in jail. They do get maltreated, and that doesn't help the situation at all. Do you want to do your goodies, Debbie?
Has anyone not seen Diastat or seen how to use it or how it comes? Okay. All right. If you... Oh, great.
Do you have a question?
No, never seen it. For those of you who have not seen Diastat, it does come as a twin pack. This is actually a real pack. And it comes already pre-dosed, everything is set. What I would caution, because 20 years later, there is on here, not on this one, a big note that says, attention pharmacist, please dial and block before giving things. Because Diastat comes as, if for 5, 7.5, or 10, and it comes into 20, which is good for 12.5, 15, 17.5, 20. And the reason it's called AccuDial is because you're supposed to dial it and lock it. And so I always tell our patients, make sure when you get this, that in the little window, the dose we told you that your child or adult's going to be on is in there, and that there's a green band around that says ready. Because if not, that patient is not getting the correct dose. And we've seen that time after time after time, that doesn't happen. So it's pretty, I would say it's pretty idiot-proof to be able to do this. So, so it's, yes.
One thing else I would tell people to tell their patients about rescue meds. We look and there's how much, we give it, well, maybe I'm talking to adults and children mostly, but I'm sure it happens in adults too. If somebody's like on diastat at home and they're getting 10 milligrams and they continue to seize, you have to increase their dose. It's kind of not a matter of like it seems like too much though. If it's not working, it's not working. It's like alcohol. Sometimes people can get high on one drink. Some people need two. So I think what we have to realize too, if we're giving a rescue med, whatever it is, midazolam, Valium, and it's not stopping seizures, one of the things you have to think about is increasing the dose.
Yeah, in the study, when the radar study was done, all patients got a second dose. And as it turned out, what we found in the research was it actually wasn't it actually wasn't required to give it. So we really didn't. But in the study, everybody got a second dose. Whether it was 12 hours, and I can't remember if the kids got it 4 or 8. I don't remember, too long ago. But we didn't really need it. But what we find is we tell our patients, well, the caregiver, if you've given the diastat and they're still seizing, first of all, it does take about 8 minutes for it to really be absorbed and get in. But if they're still seizing, give the second dose, And at that point, you might need to call rescue. Maybe not. But, most patients with epilepsy that are used to chronic benzos, it doesn't faze them. So, and Pat's right. Sometimes you actually do need to give a higher dose. You can't just go, diastat's done milligrams per kilogram by body weight and age. So, but, sometimes just depending on what, we've got patients who use Klonopin. They're on Onfi. They also use diastat, depending on what type of seizure they're having, And we have to argue with the insurance companies all the time why they need all of those at home. But it's dependent on what their seizure type. They may use diastat for a cluster of seizures, but they may use Ativan or something else for a more, well, I don't know, but we use it for different things. So, it really does have to be very individualized, which goes back to you really need to have a very good talk about the specifics of what these seizures, look like. The other thing I would just like to say, because this happened many, 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 many years ago, prior to us actually having rescue medication. And we had an adult patient that was actually in one of my research studies, and he had really bad postictal psychosis. And his psychosis would last days. And, he had the religious hallucinations and all that kind of stuff. And I will never forget, he actually jumped out of his parents were driving. He actually jumped out of the car into traffic and was hit, and was in an ICU. So that and it was days later, but he still had a postictal psychosis. Yes?
I think someone had mentioned earlier, and maybe I misheard it. I thought they said it was possible for the postictal psychosis to not start until 48 hours after seizure? Sandy, you said sometimes postictal psychosis may not start for 48 hours? Right. I know.
She was asking, she thought you had said 48 hours.
I think, it may not be frank psychosis. Patients may simply be have a delirium or a post-ictal agitation, and then it gets missed. So, it's something that you've really got to be aware of, especially in the EMU, because it's common. And, patients may not come with a history of it, but just because we took medicines off rapidly, it provokes it. A lot of the anti-epilepsy medicines have mood-stabilizing effect. And this is probably why it unleashes those sorts of behaviors.
And is there any warning, any indication at all? Or
not necessarily. And I think this is another reason why we don't pay a lot of attention to the post-ictal period and to post-ictal behavior. We should. But gradually, if it's setting and you'll find that you go in the morning and the patient doesn't recognize who you are, maybe somebody that has known you, or they're basically confused, they're a little bit disoriented, and then they start getting paranoid. Usually that's the first thing, the sort of major point. And then the question to them is, are they hearing voices, or are they seeing things that might not be there? And those are the sort of hallmarks that you'd look for. But it's not uncommon.
Other questions or comments? Yes.
So you're speaking a lot about pediatric populations or adult populations. What about geriatric? In terms of clusters?
I really wish.
Clusters,
Well, I think clusters can occur at any age, but didn't you show us, Debbie, Kathryn showed a slide that showed there was less likelihood later in life. But I've seen many elderly people develop post-ictal psychosis, full-blown post-ictal psychosis. And it's really quite upsetting to see it because it's a vulnerable population. And you can't discharge them like that, so you've got to keep them in a hospital setting until it's resolved.
And I would assume it's a very different patient caregiver, family care.
Yeah. It's very frightening for families if they've never seen it before. To have a husband suddenly not recognizing his wife and being paranoid and.
That kind of gets back to she was mentioning about what I'm hearing from new research coming out is that it gets diagnosed as early dementia or Alzheimer's instead of actually being brought over to that.
Yeah, you would think that it would be easy to correlate the two. Yeah.
Any other questions? Yes.
So do you think did you say that the elderly are more vulnerable to post-ictal psychosis? Is that what you said?
No, we said less. We probably less to clustered seizures, but less to clusters, but not immune from post-ictal psychotic behavior. Yeah.
Well, thank you.
Yeah, thank you for coming and making music with us in Tennessee, in Nashville. And again, we just thank the sponsors and Alex for helping so much with the slides that went back and forth a number of times, and for bringing us all together. And I hope you've enjoyed it.